Welcome, everyone. Thank you for being here. This is the first Universal Healthcare Work Group meeting. Glad everyone was able to make it in. I know it was a little crowded in the Capitol today. My name is Jamie Strauss-Clark. I'm going to stand back here so I'm not blocking anyone off. My name is Jamie Strauss-Clark. I'm going to be facilitating. I've never worked in this room in particular, so please signal to me if you're having trouble hearing. I'll try to use the mic rather than my outdoor voice today just to make sure, because this is a fairly large room. We have a really jam-packed agenda today, so I'm going to be working us through this pretty quickly. Most of today is going to be information sharing. Our real deliberations as a group are going to start at subsequent meetings, but there's a lot of information to put out your way. One thing to share with you is we are having technical difficulties with the video projector, so fortunately we've printed all the materials. I tend to find PowerPoints are easier to look at on printed materials anyway, so we'll be distributing those as we get to those points in the agenda, but that's just something to note. A couple quick housekeeping items before we start our introductions. Restrooms are out this door over here. Men's are to the right and women's are to the left. Healthcare Authority has provided us with snacks to get us through the 4 hours and coffee and water, so please help yourself, keep yourself nourished. There will be a break halfway through, so I'm going to ask everyone to hold on emails and other distracting things until we get to that break. And please do take a moment and silence your cell phones so that they're not distracting to your colleagues here. And then finally, if there's an emergency, I certainly hope there's not, but if there's an emergency, the most expedient way out is out this back door and to the left and straight. And Sean, where's Sean? Sean will be our leader. He will lead us all out. So if there's an emergency, please follow Sean. He will get you out of the building. I will review the public comment process, but Sean is also the person to go to if you plan to, or would like to make a public comment today. He's taking sign-in names, so please go see Sean if you would like to make public comment. That's going to be at the end of the agenda today, the last 20 minutes, but I'll review the process for all of that before we get there. Let's take a few moments. Oh, one last thing. I want to orient you to your microphones because I understand, or actually Pat's going to orient you to your microphones because they're a little bit tricky. Hold on a second.
Thank you. Hi, everybody. So only a certain number of these microphones can be on at the same time. So what I'd like you to do is turn it on. It'll turn red. I'd like you to speak into it. A little more Mick Jagger than Tom Jones. So get in close, even though it seems like you don't want to be loud, but it is most efficient for the recording and for people around you to hear. It's also what a lot of people I see do is they'll turn it on and then they'll scoot it across the table. You can scoot it across the table and then turn it on. It won't make so much noise. If you have any questions or concerns, or if anyone in the back can't hear, you can just go and up, and I'll turn it up for you. Thank you. Thank you.
Thanks. And we'll get the hang of it. If we make a few mistakes on the first tries, that's no problem. We'll get the hang of how to use this. All right, I'd like to have everyone introduce themselves so we all know who's sitting around the table. And then after that, I'm going to walk you through the materials in front of you. As I said before, we have a jam-packed agenda, so please forgive me for being really aggressive about keeping us on schedule. But I'm going to ask everyone if you could just take 30 seconds max to say your name and your role and what perspective you're bringing to this work group. And our chair, Sue Birch, is going to start it to model how we're going to do this.
Good afternoon, everybody. I'm Sue Birch. I'm the chair. I'm the director of the Healthcare Authority. By background, I'm a nurse, and I've been a health policy nerd for decades.
Move to Aaron Katz.
Hi, I'm Aaron Katz. I'm on the faculty at the UW School of Public Health, and I've been a health policy nerd for about 45 years.
And I'm Dennis Delwo, and I was a state legislator, chairman of the Healthcare Committee, 1993 and 1994 process when we built the Basic Health Plan and the wonderful healthcare program that was then repealed.
My name is Lynette Veers. I am the president of the Washington State Nursing Association, and I come here in strong support of problem solving.
Hi, I'm John Braun. Oh, it's loud. I am the state senator for the 20th Legislative District, which is just south of Olympia, and I am the ranking member on the Senate Ways and Means Committee.
Good morning, everyone. I'm Nicole Macri. I'm the state representative from the 43rd Legislative District, which is the downtown Seattle to just north of the University of Washington campus. I serve as the vice chair to the Healthcare and Wellness Committee in the House.
Thank you. Hello, my name is Carrie Glover. I do policy work for JJIC Public Affairs, and we represent several patient groups, so I'm here to represent the patient perspective, especially those with chronic disease, such as our clients, the Bleeding Disorder Foundation of Washington and Susan G. Komen Puget Sound.
Good afternoon. My name is Randy Scott. I am the Northwest rep for a group called the Pacific Health Coalition, which is a group of about 49 mostly Taft-Hartley trusts that provide health care benefits to members of local unions in Washington and Alaska.
Good afternoon, Beth Johnson, currently CEO of Coordinated Care, one of the Medicaid managed care plans, as well as participating in the individual market. I probably come with 31 years of experience, healthcare experience here in the state of Washington, both on the payer side and on the provider side. I've worked kind of both areas.
Hello, everybody. Thank you so much for inviting tribal representation to this work group. But I do want to point out from the get-go, I'm here on the behalf of the Port Campbell Slalom Tribe. All tribes are sovereign governments, so I do not come here speaking for all 29 tribes in the state of Washington. I've been employed by the Port Campbell Slalom Tribe since 1995, and the Port Campbell Slalom Tribe has always been heavily involved in alternate resources, especially a lot of experience with the basic health program. Thank you.
Good afternoon. I'm Rich Kohar. I'm a family physician and work in the community health centers, Country Doctor Community Health Centers in Seattle. So recently I was the medical director. I've spent my whole career in the safety net, and I hope to speak for underinsured, uninsured, that experience of living that life, and the left outs as we create a better system.
Hi, my name is Pete McGuff. I'm a family physician, clinical faculty at the University of Washington, and so I'm bringing the provider perspective. I'm past president for the State Medical Association, and was around when basic health and the last go-around on healthcare legislation was done.
Hello, good afternoon. I am Carrie McKenzie. I am CEO of Gold Core Innovations, and I bring the small business perspective.
Good afternoon. I'm Aaron Spark, Government Affairs Officer for the Seattle Indian Health Board and Executive Committee Member for the American Indian Health Commission of Washington State, which is the health policy body for all 29 tribes and 2 urban Indian health programs. And apparently the only one who has Blue Friday at work today and forgot that I had an in-person meeting. But I did have this jacket, so I'm happy to be here with it on.
Whoa, that's really loud. Good afternoon. My name is Bevan McLeod. I'm a co-founder and president of Alliance for Healthy Washington. This is near and dear to my heart because this is a piece of legislation that I helped write. And I also bring the perspective of a single parent that is underinsured.
My name is Rod Tritko. I'm a cardiac anesthesiologist by training. I've worked in the acute setting for over 30 years. Now I'm working as a solo practitioner in the outpatient setting. I've also been involved for 30 years in organized medicine at the local, state, and national level. And at the national level for the last few years, I've been working very diligently to try to get the AMA to start looking at options other than what they had been promoting for many years. Thank you.
Good afternoon. I'm Jane Byer, and I am Commissioner Mike Kreidler's Senior Health Policy Advisor. So I'm here representing the Commissioner and also looking around the room and remembering when I was staff to Representative Delwo and working on the Behavioral Health Commission. So it's great to see so many of the same faces and new faces at the table.
Good afternoon. My name is Zach Snyder. I'm here today on behalf of the Association of Washington Healthcare Plans. We represent the 12 major medical plans in the state of Washington, covering about 7 million people in the state. In my day job, I'm Director of Government Affairs for Regents Blue Shield, and I've spent my career working in health policy on both the payer and the provider side.
Good afternoon. I'm Lisa Hume-Schultz. I'm the Director of Strategic Initiatives at Planned Parenthood Votes Northwest and Hawaii. I'm here to represent the about 100,000 patients that we serve annually here in Washington who similarly face a lot of unmet healthcare need and are under and uninsured.
Good afternoon. I am Shirley Prasad. I'm a policy director with the Washington State Hospital Association. So the association represents all 109 hospitals and health systems in the state.
Hello, I'm Kelly Powers, and I'm a consumer representative, meaning that I have been buying independent or individual insurance for over 20 years. I have a lot of war scars from this experience, and I've been on the exchange since 2014. Thank you.
Barbara Dietering, family physician, here as the board member for Washington State Medical Association. I'm a practicing physician and also a medical director at Kaiser Permanente, so representing organized medicine and the medical community of Washington State.
And good afternoon. My name is Mary Beth Brown, and I'm from the Systems Transformation Team at the Department of Health and representing Secretary Wiesman today, and I represent the public health interest.
Good afternoon. I'm Christine Jabert. I'm with the Washington Health Benefit Exchange. I'm representing Pam McEwen, our CEO, who today is in D.C., and we are just here representing the consumer experience in the individual market in Washington.
Hi, I'm Brenda Snyder with the State Treasurer's Office. I'm the policy director there, but our office operates the state's cash flow, so that's our perspective.
I'm Senator Emily Randall from the 26th District. That's Gig Harbor, Bremerton, and Port Orchard in the Key Peninsula. I serve as vice chair of the Senate Health and Long-Term Care Committee and worked with Representative Macri on this legislation and budget request. I learned first about Washington's role in expanding healthcare when my sister benefited from 1993 Medicaid expansion, and I spent my career raising money on the nonprofit side for uncompensated care for healthcare providers. So I am thrilled to be working with all of you.
Hi, I'm Robin Williams from the Office of Financial Management. I have the Medicaid and affordable health care portfolio. I'm a budget assistant to the governor.
Hello, I'm Ronnie Shore. I'm a pharmacist who spent his career excuse me, working with underserved populations in substance abuse, mental health, public health, and spent 10 years in King County Jail working as a pharmacist. And I failed miserably at retirement and am very strong advocate of universal health care.
Hello, my name is Mohammed Shidani. I work with the Somali Health Board as a community advocate and a community organizer.
I'm Don Hinman, and 45 years ago I joined a group of people to start Yakima Neighborhood Health, and for the last 40 years I've been chairman of the board of that organization. We started with one employee, and now we have over 300 employees, and I don't know how many patients we see a day, but it's a bundle in 8 clinics. And we're the lead navigator agency for Kittitas County and Yakima County, and 50,000 people are signed up for the Affordable Care Act in those 2 counties.
Good afternoon. I'm Patrick Connor with NFIB, representing Washington's small business owners. We're about 98.5% of all the 500 or so thousand small businesses in the state. Businesses in the state. Our members tend to purchase in the individual market or in the association health plan market. So sensitivity to price, access to affordable quality care are certainly a couple of our paramount concerns.
Hi, my name is Sybil Hippolyte. I'm with SEIU Healthcare 1199 Northwest. We're a union of 30,000 healthcare workers across Washington State, and we are very invested in expanding healthcare access as much as possible in Washington State. So excited to be here. And I would just add, I have a back injury, so I'll be standing up. I'm not trying to leave. I just need to take care of myself.
Thank you for letting us know that. Actually, if anyone, I know these chairs can be very uncomfortable for a 4-hour period, so please do feel free to stand up and move around as needed. I would like the project team to just take a moment and introduce themselves as well. They'll be the team that's supporting our work group process and providing us with information and data as we need it. So if I could just ask each of our project team members to say your name and what your role in the project is. I'm going to pass this mic down.
What if I go first, since I've been standing and walking around anyway? My name is Katie Rogers, and I'm the project lead from Health Management Associates. We were the successful bidder on the Universal Healthcare Work Group project, and we're very excited and humbled to be here today. We have amazing subject matter experts, and we have Jamie, of course, who's a professional facilitator with a lot of great experience, and we have our actuary consultants as well here from Optimus, so they can introduce themselves.
Hi, my name is Nora Leibowitz with Health Management Associates out of our Portland, Oregon office, and have become part of this team because I have expertise particularly in individual and group coverage under the Affordable Care Act, as well as the Medicaid program, and have worked over the years on a number of citizen work groups that were moving toward making improvements in the health system, particularly in Oregon. So I'm excited to be part of it here.
I'm Liz Arjun. I'm a consultant with Health Management Associates in our Seattle office, and my expertise area is really in the Medicaid and CHIP space. And I've worked with many of you here in the past, in past roles, and it's exciting to be with you all again and on this new endeavor.
Hi, I'm Janine Smith from the Portland Health Management Associates office. I'm a family physician and did 15 years running the policy shop in Oregon through a lot of rounds of health reform, and know several of you from that.
Hi, my name is Jared Nason from Optimus. I am a part of the team to support the fiscal analysis, enrollment analysis associated with the options that are chosen. I have over 21 years of experience with publicly funded healthcare.
Good afternoon. I'm Rochelle Alongi, and I am the Policy Communications Manager for Healthcare Authority. So communications, I'm kind of the lead for this work, and so any press releases, announcements, website, that's me.
Hello, I'm Tamara Henshaw. I'm the project manager, and I'm in charge of logistics and facilities and making sure y'all have tables and chairs to sit in. So.
Hi, I'm Sean O'Neill, and I'm the Legislative Relations Manager at the Washington State Healthcare Authority, and I'm the project lead, so I kind of oversee all of the internal healthcare authority stuff that goes on to arrange these meetings, and also am the lead point of communication with HMA.
Hi, I'm Steve Schramm. I'm the founder and managing director of Optimus. Optimus has done statewide healthcare reform initiatives in more than 24 states in the last 15 years, and we're very excited to be part of this initiative.
All right, a couple more housekeeping items before we get started. First of all, I want to review the agenda for today and our objectives for each portion of today's work. You'll see an agenda on the table in front of you. As I mentioned earlier, the main purpose of today is to meet each other, understand how this process is going to work and the timing of it, and then have some level setting so that everyone's having the same baseline information that we're starting with. So this is going to be a lot more of us talking to you today than future meetings. Our objective for future meetings is more of you talking amongst each other and me facilitating that. So bear with us on today, and then our subsequent 8 meetings will be much more of a dialogue. For today, after we get through our initial housekeeping and welcome and introductions at 1:30, I'm going to walk you through what we have now for our work group process, which is primarily the timing. We'll talk a little bit more when we get to that portion of the agenda about how we're going to work out the framework. And also we'll tell you a little bit about the stakeholder engagement process and how we're going to engage community members and other stakeholders to gather information to inform our deliberations. At 1:55, very precise on the timing here, we're going to talk through the charter that I distributed to you via email a week ago today. Get any feedback on that, any changes that we need to make, and then our objective is to affirm that, and that'll be kind of our constitution moving forward. Then we'll take a break at 2:20, a short break. I apologize. We'll try to build in longer breaks in future meetings, but today was just really jam-packed. 2:30 is when we're going to start our presentations. And so at that point, you're going to be hearing both about the history of, you're going to get a landscape of healthcare in Washington and how it's delivered, and then you're going to get a briefing from the WISIP report, the Washington State Institute of Public Policy, that I believe a number of you probably reviewed, and you're going to get a briefing on that. We're not going to be able to do a deep dive today into the history of healthcare reform in Washington, but understanding that there's a lot that precedes us, and many of you around the table have been involved in all of that precedes us. We will have an opportunity to address that in more depth at a future meeting. After the presentations, we'll do a quick run through of action items and next steps. We'll have a little time after the presentations and during the presentations for you to ask clarifying questions. Then we'll do action items and next steps, and then we'll have 20 minutes of public comment. So before I explain how the public comment's going to work, I do want to walk you through your notebooks. These are yours to keep for the work group process. And store your materials. You'll see when you open it, there's an administrative tab, and in there you'll have the roster, so all the names of the folks around the table. The next page, you'll see the project team, and contact information at the bottom. You'll see my contact information. I am your point of contact. You don't have to worry about who do I call or ask or whatever. I can triage and make sure it gets to the right person. So if you have a question, you have feedback, particularly feedback on how these meetings are running. I'd love to hear. I have a learning mentality, want to always be improving, so please do share your feedback. Or if you have something that you would like to share with the greater group, please send it to me, and I will make sure it gets to the right person or people. You'll also see at the bottom of this page the link to the website that Rochelle has set up. This is where we're going to be posting all of our meeting summaries, recordings of these meetings, so that folks that aren't some of our community members who aren't necessarily able to make it here today can review the meeting and listen. And there's also going to be, that'll be our portal for our stakeholder engagement and public involvement. So please do bookmark that website, because that's something you will be going back to throughout this process. The next page, you'll see the draft charter. This was the document that I sent you a week ago, so we'll work through that today. And then finally, you'll see the schedule. This is the schedule of work group meetings. There's 9. There's one I want to note that's TBD. It's the February meeting, and that's during session. So we're going to be working with our members of the legislature to work out when timing will be possible for them, because I know that's a busy, busy time for our legislators. So that is your notebook. You'll see subsequent there's tabs for all of your meeting materials for the upcoming meetings. We will be providing you with printouts of our presentations today, so you can put those in your notebooks, and then store your materials as you're working through to make life a little easier for you. Any questions before we move on about your notebooks? Okay, last thing in housekeeping is I just want to review the public comment process. As I mentioned before, if you're interested in making a public comment, please do see Sean at the end of our table over here. He's got a sign-in form, and you can sign in. We are going to be taking public comment for 20 minutes. It's going to go in the order that you've signed up on the sign-in sheet. Please do, if your last name is one that requires some finessing, please spell it phonetically so I can do my best to pronounce it correctly. I always want to pronounce your names correctly. The way it's going to work when the public comment period starts is we're going to have, it's a little awkward, I apologize, but we're going to have folks sit at the table here. So I'll have Patrick and Sue and Sybil turn your bodies so you can see them. I'll put the microphone there, and you will have 2 minutes to make your comment. I will have a timer that will let you know when you have 30 seconds left and when your time is up. And I'm going to ask, out of respect for your fellow community members, that you follow the timelines, the 2 minutes. I will help encourage you to end your talk at 2 minutes if you are going over. As I said, I will call you in the order that your name is listed, and what I'm going to do is I'm going to say the first name, so the person who's speaking, and then the 2 people who are on deck, and that way we can keep things moving pretty efficiently. If we have not many people signed up to comment, I will offer an opportunity for anyone who hasn't signed up to come up. I do want to make a really important point here, which is speaking into the microphone is not the only way, or even the most important way, to participate in this process or to provide your input. We are going to have online comment forms. There's an email address where you can send comments. So for folks who do not feel comfortable speaking in a microphone or can't get to Olympia on one of our meeting days, or if one day if we have a really long sign-in sheet and you're not able to make a comment, please know that your voice can be heard. There are other ways that you can share your input. What I'm going to do for our work group is when we get comments that are written, we're going to distill those and share key themes with you. Excuse me, I'm going to stay away from the feedback there. We will distill the outcomes of those comments and share those key themes with our work groups so that you understand and you're able to hear what folks in the public are saying. And then we'll talk shortly about this, but there will also be 2 public comment periods as part of this process where you'll get more input from the public. So that's how our public comment period is going to work today, and I'll repeat those guidelines when we get to that time in our agenda. Okay. Let's move on then. So next on our agenda is we are going to walk you through, first of all, quick introduction to our team here from Sue, and then we're going to walk you through our timeline for the work group meeting. So.
Yeah, thank you. So I want to just call out that HMA has really assembled a fabulous team to help us journey through this universal health work together. We can wander far and wide, but that is not the best use of our time. So they will be in the key role of kind of narrowing and shaping and helping us go through this. I remind you all that the charge of our work group, which many of you reviewed as you went through the questionnaire process, is before you. So oftentimes when we speak to help our facilitators and to go through the process, just think about our comments and how we are fulfilling these key bulleted areas. Because I do think they have a tall order to keep this process moving and helping kind of distill efforts. It's our job to think about the material that's coming before us and to shape that, but it will be the legislature's job to really make decisions about the report that we put forth. So I just want to really clarify that they're in a little bit of a tough role, and at times when they need support, I too will be leaning in to say, we're not decision making, we're thinking together, and but do use this as a guide as you make your comments and as we journey through this process over the next period of time. So thank you to the HMA team and all the supporting team that really has a pretty extraordinary bench of expertise. It's fabulous to see old friends, and this will be a great process as we go through.
Thank you, Sue. So I'm going to turn it over to Katie, who's going to, if you look in your notebook again under the administrative tab and you go to the page that says Universal Healthcare Work Group Schedule, Katie's going to walk you through that a little bit.
Hello again. So you'll see that, has everybody got to the right page? Excellent. That we've listed out the dates of all of the future meetings with the exception of February. I think we already explained that that's during legislative session, and we're going to try to find a good time and for everyone to get together, but we have members of the legislature on our work team. We want to honor their commitments and make sure that they can attend as well. And you'll also note that we're going to hold a meeting in Seattle and one in Spokane. Our friends on the east side, we're waiting for the passes to be clear so we can travel over there safely, perhaps. Also, I wanted to remind everybody that we do have these 3 reports that are due to the legislature. The first one is just a summary of where we are today. It's due on November 15th. It'll be things like, this is our group. We've had our first meeting. We reviewed X, Y, and Z, and our future plans are to go through A, B, and C. In the springtime on mid-May, we have another report due, and that report will have a lot more meat around the bones of the direction that we think we're going. I also want to let everybody know, just to, if you haven't got this message already, we are looking for not necessarily one answer. We have an actuary team here who can model up to 2, maybe 3 options for us. So keep that in mind as you're thinking through your good ideas and communicating with your fellow work team members that there's more than one good idea that can come out of this. So in any case, hopefully by May, we'll have our arms around our, our final couple of great ideas that we're going to put forward and continue to work on. Then at the end, at the middle of November in 2020, our final report will be due to the legislature, and that will have all of the cost information, all of the detailed information that really fleshes out the ideas that this work group comes up with collectively. Any questions on that? Okay. And please keep in mind that the next time you see this work schedule, it will have more content around what we're going to be doing in these meetings. What we really want to make sure is that during the one-on-ones that Jamie and I hold with you, that we get your good ideas about things that are important to you as work group members to bring forward and to be discussed here with the team. And that's going to really shape our agenda moving forward. So we definitely hope that you will all be able to attend the one-on-one meetings that we schedule with you. And also, as we hear information in the work group meetings, that could affect the agenda for the next work group meeting. It's a living document that we want to honor your participation in and make sure that it's captured where we need to go. Yes, Aaron.
It actually goes back to this, the input that we might receive not during meetings. And you say that you're going to distill the input. And I'm just wondering if, in addition to the distillation, we'll also have access to the whatever full emails or input. That would be helpful, I think.
So I'm hearing that it would be of interest to have the raw material that people are contributing. Yes, we can make that available too. The purpose of distilling is also just to make it easier to get through it. But once we also have a better sense of the volume, we can have feedback we're going to get. We'll be able to show that. I did want to mention one thing too that I should have mentioned before when we were talking about public comment, which is folks that are planning to make a public comment. If you have written notes, please do share those with those after. That'll also be helpful to share with our work group members. Any other questions? Actually, Aaron's question segued very nicely to the next thing that we're going to talk about here, which is our stakeholder engagement plan. So I'm going to ask Bevan to take one and pass that down. What I'm distributing here is a draft thank you, Ron, draft stakeholder engagement plan. This outlines the tactics that we're going to use to make sure that we are gathering input from community members and other stakeholders in the outcomes of our work group. The objectives are fairly straightforward. The first is to inform stakeholders out there who are not sitting around the table about the purpose of this work group, the process of developing recommendations to the legislature, the timeline, and how and when they can get involved. That's a key objective of our engagement. Another one is to gather input, and this is also important, to gather input from the public and stakeholders to inform your deliberations as a group. We have, as we said, subject matter experts and experts in actuary work and finance, but we also want the experts out there and living these experiences to be providing their input. So that's a key purpose. And then finally, demonstrating transparency and trustworthiness. Those are our three key objectives. Some of the tactics I've already mentioned. We have a website where we're going to be posting all meeting materials, meeting summaries. I do want to note that you will receive draft meeting summaries in advance for your review before they get posted to the website. So I'll ask you to review it and let me know or let us know if you see anything there that was maybe captured incorrectly or you have a different interpretation of the outcomes of the discussion. All of that will be reviewed and edited before it's posted. We're making, as you've seen, all of our work group meetings open to the public and providing a public comment period at every work group meeting at the end. We are providing, as I mentioned earlier, alternate ways for people to make comments or provide their input. And then in November of this year and then May of 2020, there's going to be a public comment period. So after the initial reports are published and available to the public, and we'll do some kind of summary document to make that accessible to them. Just a moment, Zach. Okay. We will take public comment at that point. Zach, do you have a question?
Yeah, so how much time are we going to be giving the public to review the material so that they can make comments before the meeting starts?
So that's a good question. So I want to make sure I understand though. So are you saying how much time are we going to give the public to look at the meeting materials for each meeting so they can make a comment at the end of the meeting, or are you talking about something different?
So I think it'd be a good idea to have the materials that we will be looking at available for the public so that they can review it before they come here, so that they can be prepared to comment on the materials that we're reviewing.
I understand. So for example, if they could see the presentation materials that we're going to be presenting at the meeting in advance, then they can prepare their comments for the end of the meeting. Okay, I can't answer that question now if that's possible, but I will get back to you. I will discuss with the team and then come back to you with an answer to that. That segues to another question though that might come up, which is how much time will folks have after the meeting to review the recording and provide a comment. And so we're going to post the recording as soon as possible after the meeting, and then they will have 2 full business days, 48 hours, to post comments on that meeting. We have a SurveyMonkey tool or something like that to collect those comments. There will also be an available email address where they can send comments at any time. And then after the reports, there will be a defined comment period, 15 or 30 days. We'll let you know what that timeline is going to be. But Zach, we'll get an answer to your question and get that back to you. Yes? Oh, you do? I'm sorry. Okay, I'll give you this.
Okay, so as far as having materials up on the website for folks to be able to go look at it, we're aiming for 2 to 3 days prior to the meeting. So, yep.
Okay. Last thing I want to let you know is how we're going to notify folks that this process is happening, that these meetings are happening. There's a Gov delivery channel, and we're going to be providing updates to people that are signed up for that on the work group timeline, process, and any updates. We encourage you as work group members to share this information, and Rochelle will get that out to you so that you can distribute that, share that information to your communities and constituents. The more that folks know that this is happening and that there are opportunities to provide comment, the more robust the comments that we're going to receive will be. We are going to conduct a round of statewide media outreach announcing the formation of this work group. There's already been a press release that's gone out, I understand, and there will be some additional outreach around how the public can provide feedback on the deliberations when we do our public comment periods. So any questions about stakeholder and public engagement? Yes, Patrick.
Thank you. To follow up a bit on Zach's question, it seems to me given the spread between the meetings and the duration of these meetings, it would be, I think, asking quite a bit of the public to be able to go through 4 hours of a video and then have just 2 days to comment. So given that most of these meetings are more than a month apart, perhaps the team could take a look at maybe extending that public comment period to more adequately take into consideration people's schedules, particularly if you're having Friday afternoon meetings, then giving them 2 business days to respond.
So, battery pack there. So Patrick, I'm hearing that you would like us to consider whether it would be possible to add more time to that period after the videos are posted so people can get through all the material. Okay, I saw some nodding heads, so we will discuss that and get back to you with an answer on that. Other questions? Okay, we're doing really well on time here, so that's good. It's always good to buy us some time. Let's move on to the charter. So if you can look in your notebook just before the timeline we went through, you'll see the draft charter. Did everyone have a chance to take a look at that before? I know Kelly got it late, so I apologize. Did anyone have any questions or comments or concerns on the charter that you would like to raise? Yes, Aaron.
So I sent you a note about this when I didn't think I was going to be here, and I realized that the charge to the work group was in the budget proviso. But my feeling is that these 5 bullets are probably much more than this group can contend with, even knowing that we're not decision making, that we're generating ideas, and in particular, it seems to me the second and third bullet, transparency measures and evidence-based practice, are really, first of all, there's a number of organizations and groups around the state that are working on that. And number 2, I don't think this group, being as large as it is very well placed to deal with those. So I would advocate for us to set as a priority the first and fourth and fifth bullets, because these are the high level, really this is the context that would drive whatever policy approach the state decides to embark on. So that would be my plea. I don't think we can do all 5 of these well.
Does anyone have a reaction to Aaron's suggestion there? Yes.
I like the suggestion of narrowing the focus, and I think the first, fourth, and fifth bullets are important bullets to pay attention to, but in the third bullet, there is a focus on affordability, and I want to make sure we're not overlooking that.
Okay, so what I'm hearing is some echo of Aaron's comment that narrowing would be preferable because this is a big scope and maybe ambitious or not appropriate for the size group, but we don't want to lose affordability as a key measure here. Yes, Dr. McGill.
Yeah, I'd like to suggest that we retain innovations. I think the assumption is we know the best way to deliver healthcare. We just have to do it more efficiently. And I think that, it's going to be the innovations that help us, achieve all the key goals in here. So it's not just business as usual.
So retaining innovation sounds, I'm going to actually ask everyone, we're going to do this as a process thing, especially given this large group. If you want to make a comment, let's have you turn your table tent on its side there, and that will allow me to track so I can, and I'll do my best to see when you put it up and call you in order. So Senator Bell.
Thank you. So I just maybe push back a little bit. I appreciate the desire to narrow and focus. It's always a goal. It always increases your chance of success. But I'd make the comment that you can't get to success in 1, 4, and 5 without going after transparency, without going after innovation. It becomes unworkable. So yeah, we may not get to a perfect answer on some of these. We may have a more robust answer on some of the priorities in the charter than others. But if we consider some of them in isolation, I think we're not going to set up for long-term success. It takes all of these to have a program that's going to bring us, access and quality and everything that we really desire. Thank you.
Yes, Sybil and then Aaron.
I was just going to echo the Senator's comments.
I don't want to prolong a debate, but I don't disagree that innovation and transparency are important. That's not the point. The question is what this group is best positioned, given its makeup, size, and the time that we have, what it can accomplish. So yeah, innovation, of course, as my good friend Pete McGuff says, is very important, but I don't think this is the innovation stimulation group. So that's my point.
I'm going to circle back on that, but I want to take Aaron first.
Hi, so I just want to add, so when we worked, the American Indian Health Commission worked with Representative Jayapal on the national bill, we wanted to point out specifically the Indian healthcare system and the VA because we're both independent payers. So just looking at number 2, and I apologize right now if this seems nitpicky, but sovereign nations have a government-to-government aspect, so we are outside of the system, but we're also partners with the system. So I do want to be named explicitly as we're going along because those are 2 systems that have to work with this to make it successful.
So to clarify the proposal here, it's bullet number 2, transparency across major health system players. That should include Indian
tribal
health systems.
Yeah.
Okay. I'm going to ask our folks who are taking notes to make a note so we add that. Does anyone have any objection to making that change to the charter? Okay, thank you for that suggestion. Okay, so circling back to what Aaron said, I have a proposal to folks because I'm hearing that there's this tension between making sure that we have a scope that we can get through both in the 13 or 14 months that we're working together and given the expertise around the table. The tension with there was a lot of work done on this legislation and to include aspects that folks wanted to see addressed and the legislature really needs our feedback on. So I'm wondering if there's a way we can adjust the language here where it says to the degree possible, the work group recommendations should address to acknowledge and recognize that these are all aspects they would like us to deliberate on and touch on in our recommendations, but that there are some that we're going to actually be able to do more on than others, I think, to Senator Braun's point. Does anyone, I can't give you the exact language yet, I have to process a little bit, but does anyone have any concerns about doing some adjusting to that language to demonstrate what I just said? Okay. Yes, sure.
So
recognizing how meaty each of these bullets are, have you all thought about perhaps taking this big group and breaking it up into subgroups to talk about some of these bullets kind of offline and then bringing those thoughts and recommendations back to the bigger group?
So maybe taking like a technical advisory group approach where we do some wrestling with it and then bring it back to the larger group. Actually, that is a really effective process in some situations. So as we do our one-on-ones with folks and we think about how to work through this process, I think that your suggestion is one we should definitely consider. And I'm seeing some nodding heads, so it sounds like others think that that might be a good way to tackle some of these meatier ones. And I think to Aaron's point, if I'm understanding correctly, that there are groups around the state that already have been or are doing lots of work in this area, and we should definitely draw on that as well. Yes, our chair.
So if I could take the chair's prerogative, I just would remind you all in my opening comments, this is why our facilitators and this team has been put together. They are going to distill and bring the salient parts of the charge of this work group to us. They're going to condense, and we're going to add where we think they might have missed something. But again, when you look at this process and how far we've come in the first decade of health transformation, I think we have to lean on our facilitators and our professional staff to bring forward in these 5 areas kind of the work. And I think there might be times where we need to break out in a subgroup, but we don't know that yet. I think we need to begin this journey and rely on the professional expertise that we've brought before us. But I do believe that it is really wrong to eliminate any of the charge areas at this point.
So I think the proposal on the table that we're discussing is doing some modification to the opening language under this charge of the work group that, again, clarifies that these are all issues that are important to consider in our deliberations, but recognizing that our scope might need to be a little bit more narrow in terms of what recommendations we provide to the legislature. So I'm going to beg that your forgiveness that we do a little work on the language and send back another version that we can affirm at our next meeting. Does anyone have any concerns about that? This will be our, as I said, constitution moving forward, so we want to make sure we get it right. Sybil, did you have a comment?
I do think that we need to focus on the transparency issue. I think that one of the biggest problems with our healthcare system is that we don't understand how money is moving and why. And if we are serious about setting up a universal healthcare system where our state is responsible for putting money on the line, I think it's very irresponsible to go into that without concrete recommendations on the transparency part. Just for my personal budget, I would never say, yes, I'm going to sign up for paying for this thing where I don't understand how the money works. And I don't think our state should do that either.
Okay, so I'm hearing Sybil echo that this bullets, the transparency bullet in particular is important to keep in here, but I generally hearing from several of you that you're not comfortable with eliminating some of these bullets at this point. Any other comments on our charter? Oh, sorry, Rod, yes.
So the 4th bullet, it talks about a universal healthcare system. And I just would like to clarify, is that just a system that delivers essential health benefits, or are we also going to at least consider foundational public health services?
That question might be one that's beyond my pay grade to answer, so I'm going to look at our team here and see. You want to take a shot at it?
That's a great question. As I said earlier, we're not necessarily looking for the silver bullet of one answer. I think that with our actuary team and the diverse group that we have on the work team, we can come up with more than one option that can be modeled. And we can certainly include what the foundational health, thank you, into the discussion. Does that answer you? Or, yeah, okay. Sort of, yeah.
Okay, I see Kristen and then Patrick.
Thank you for the opportunity to comment, but I'm thinking that maybe wanted to suggest under charge of the work group, bullet 3, that we also make some reference to cultural sensitivity and cultural appropriateness. I think that'll be important to recognize in the work group if equity and healthcare equity is going to be accomplished, that it needs to be something that's sensitive to different cultures in the state. especially for just working in Indian country, seeing evidence-based practice. That's really a terminology that doesn't mean much in native context. So I think that would be nice to see that in there.
So to clarify, the proposal is innovations that promote evidence-based practice, healthcare quality, sustainability, cultural sensitivity and appropriateness, and affordability. Is that accurate?
Yeah, that sounds great. Thank you.
So we got that? Okay, good. That's Patrick.
Thank you. In terms of the bullets, there are a couple of things here where I think Erin made good points about other groups doing some of this work. So is staff or members of this group or others going to be taking a look at maybe doing an inventory of those other organizations, comparing the requirements here to our membership list to ensure that we're not missing key stakeholders, or when these particular bullets are going to be the focus of one of our meetings, having an opportunity for those groups to be able to come in and do presentations, for instance.
So if I'm hearing correctly, you're asking for our team to identify all of the work that's being done or has been done, and then create opportunities to share that information when either in presentation form or distill it for this group so that we can draw on other work that's been done in the past?
That would be helpful if it's not already part of the work plan.
Yeah.
I think that perhaps in some of the individual meetings, it might be a good opportunity for those of us who work with some of those other groups to perhaps be able to point you guys in the right direction so that you don't have to create that out of whole cloth.
Yes, please. And in fact, when we're doing our one-on-one meetings, it's one-on-one's inaccurate. Katie and I, when we meet with each of you, if you have suggestions for us, and some of the folks we've already met with, we had an opportunity to meet with a few of you before today's meeting. Most of our meetings are going to be after, given everyone's schedules. But when we meet with you, please do let us know if there are particular groups that you've worked with or material that you think would be useful to share. We'd like to see that. So thank you, Patrick. Okay, we'll take Lisa and then Beth.
So building on what was just shared about cultural appropriateness, when reviewing this, realized that health equity or equity at all is not mentioned in here. And so I'm wondering if maybe the first bullet point, there's an opportunity to talk about looking at health disparities there, using our coverage as an opportunity to reduce health disparities and move closer to health equity. I think we just need to think about that at least being explicitly written into the charge.
Okay, Lisa, so I want to make sure I'm understanding the proposal. So your suggestion is writing how, could you maybe suggest some specific language that you would put in there so I understand?
So I think something about ideas for increasing coverage and access to uninsured and underinsured populations with the goal of improving health equity or with the goal of reducing health disparities or something to that effect, I think needs to be explicitly called out in here.
And by health equity or health disparities, you mean in terms of outcomes for different people? If you live in a certain zip code, your health outcomes.
Exactly.
Okay. Mm-hmm. Okay. So to clarify the proposal of what we would add here, and I do want to remind folks that this comes from the legislation, the bullets that are here. So what I think what Lisa's proposing is maybe a clarification on the first bullet of adding not just access for uninsured and underinsured populations, but with the focusing on the outcome rather than the tactic of adding access. So any concerns about that proposal to the charter? Are yours up for a different reason or the same realm? Okay. All right. So on this proposal specifically?
Yeah, yes. I've worked on this in the past, and I believe the only database where you can get race is the Medicaid, so that would probably have to be limited to just the Medicaid population, but maybe I'm mistaken.
Okay, so I think the point you're raising, Dr. Tritko, is that the data might not be available to us to measure if we're actually meeting those outcomes. I'm going to suggest that's probably something for us to tackle down the road, but doesn't necessarily need to prevent us from saying that that's an outcome we are in pursuit of. Does that seem reasonable? Okay, Beth.
You're doing a good job of thinking on your feet, keeping all the words straight. So just a clarification, I think in that same way of words are important. It's the Universal Healthcare Work Group, but then in bullet 4 it says support transition to a universal healthcare system. And I know there have been some challenges on the national level on what does Medicare for All mean? Does that mean a reversal from employer-based health care? So the words to me are different than a universal health care versus universal health care system. That applies one system, and I would not think we're going to get to a single system. And the way that this is going to be scrutinized, I would think it's important to get our words right. So I just wanted to raise that, as it seems like an incongruency in my mind in how we take a look at that.
So it sounds like what you're suggesting is that by using the word system, we're making a presumption about what our outcome is going to be at the beginning.
When I read it, and it's one interpretation of many, I read it as a single system, as opposed to what we're likely to have is, multiple ways of getting to universal health care. So I just would suggest we might want to be clear in that, and I could be the only one that has that meaning, but I find it a little bit confusing given some of what we've heard on the national level.
Okay, so what I'm hearing is that the suggestion is to change that first sentence to ways to support transition to universal health care for all stakeholders and remove the word system. Okay.
As a possibility,
okay.
Yes.
We're going to circle back to that because I see some other tags up, and I want to confirm that that's.
I just wonder whether an alternative word to system might be coverage, because if the charge is about coverage, that doesn't imply one system, multiple systems.
It's more focused on another word could be approaches, universal health care approaches.
It just becomes, I'm sure you all will have much discussion about health care versus health coverage, and so just wanting to suggest that.
Okay. So on the table we have changing system to coverage, or I heard approaches. I want to make sure I'm tracking here, so Aaron.
So a little bit of help with the wording with what we're talking about with the culturally attuned aspect. So we've stopped using culturally responsive because there's so many different cultures. Just from the community health center standpoint, Urban Indian Health Program, we have over 300 tribes in our database, but we also see people from all different walks of life. So we don't say culturally responsive anymore. We say culturally attuned because you're just trying to do your best that you can with so many different cultures in front of you. So when we're looking at number 4, innovations that promote evidence-based practice, I'd like to add community-based culturally attuned community-based health models. Like, that's the way that we've been defining it for us. It's a little wordy, but it does take into account the different cultures of health that are out there.
Culturally attuned community-based health models.
Yeah.
Okay, and that's to respond to Kirsten's suggestion. Kirsten, are you comfortable with that? Okay, we were making a note of that. Thank you. And that is helpful education to me too, so I appreciate that. Thank you. Representative Macri.
Thank you. To Beth's point, I want to just draw our attention to the section above the charge, which says about the work group, and the final sentence of the first paragraph, which says the legislation specifies that the universal healthcare system may include publicly funded, publicly administered, and publicly and privately delivered healthcare, which I think tries to broadly define what that we mean by system.
So that's helpful too, because that echoes that the intent was to make it be broad. Okay, Don.
The only thing that I see, and I can probably be involved in delivering healthcare for 40 years, is I can articulate probably 10 things that are going wrong today. And if you don't really define those things, it's really hard to come up with a solution. And one of the problems I see with this whole thing is it's more talking about solutions and not talking about the problems that exist today in the system. And there are some really serious shortcomings that are occurring, and the solutions are pretty simple if we recognize what's going wrong. And I think we need to kind of get that inside of each of these areas. I really like what's being said here. But if you don't start dealing with what's going wrong right now, you'll never come up with a solution that's really going to solve the problems.
So Don, if I'm understanding correctly, it sounds like you would like us to acknowledge somewhere in here that this needs to be about solving problems, specific problems with the current healthcare delivery system.
We need to articulate what the problems are. I can tell you right now just to whip off a couple of them, is being able to share medical information from client to client, sure, provider to provider, is just a great example of doing it. And then also affordability, by why people don't buy. And I can tell you, you can probably drop the price 75%, and the people that aren't buying today aren't going to buy in the future unless you really dramatically change how we pay claims after deductibles and coinsurances. But we need to start talking about those things, the reason why it's not working today.
Okay. I agree with you. I think you're right. And here's my thought on what you've just said. I don't necessarily think we should change the language in the charter for that, but I do think we should consider how we dedicate some time to really understanding what the specific problems are and then doing some problem solving. And in fact, today with the presentation from Washington State Institute of Public Policy, we're going to do some diving into that. And then when we get to do our one-on-one with you and others, I'd like to know if there's more or specific areas that you're interested in doing a deeper dive in to understand. So I think your point is really important. Let's see, I apologize, I might have lost track of who came first, but we'll start with Zach.
So because the charge was taken directly from the statute or the bill, I just wonder if we deviate too much from it, will we be delivering something to the legislature that they didn't ask for?
So Zach, are you hearing anything specifically in this conversation that makes you fear that we're deviating too much from what the legislature asked for? Is this more of a global caution for us?
Just the caution. I don't know. I'd have to see the language written out. But if it deviates too much, would we be delivering something they would look at and say, well, we asked for something else?
So just sort of along the lines of what Zach said, as a 20-year legislative staffer, I'm always sensitive to what the legislature explicitly asked for. But it almost sounds like the discussion that we've been having are around principles. So there's a principle of health equity. There's a principle of being culturally attuned. And so maybe one of the things that the group can consider is not sort of straying from the charge of the work group, but having a discussion about the principles that would guide the work that we're doing. For example, where we've identified that part of this work is identifying where there are roadblocks to advancing and considering those as well. So it's just a thought.
So it sounds like I'm hearing two things. One is we want to make sure that we are considering what the legislature asked us to do before we deviate too much from our charge. And the other is that one way we might be able to start to deliberate on and tackle some of the issues that folks are raising around the table is to have an early discussion on what are our guiding principles, or what are our, how are we going to evaluate proposals. We just had this conversation with Dr. Tricker yesterday, this very conversation about coming to some agreement on principles or evaluation criteria. So I think that's a great suggestion. Dr. Tricco.
Getting back to the revising system to coverage, I would speak strongly in opposition to that. The purpose of the system is to deliver the top 3 bullets in Spokane. If I go into exchange, I can get coverage. I have horrible access and affordability, so I would keep system rather than switch to coverage.
I'm hearing an argument in favor of keeping system. Switching coverage?
Yeah, it's fine. I mean,
okay.
It's whatever the group thinks.
Okay.
It certainly is just different ways of semantics. But I think we're all after the same thing, which is the affordability and access and coverage.
Well, and I think now we have some clarification too on what we want to make sure we preserve in here, which is that we don't want to preclude looking at multiple ways of getting at our objective. So that's helpful. We'll take Bevan and then Dr. McGough.
Just super quick. The last bullet point, it says options for revenue and financing mechanism to fund the universal healthcare system, right? So I think in terms of guiding for our staff and folks who are going to be looking at the actuarial analysis, that needs to be there for that kind of research to take place. Otherwise, I think we'll jump down a rabbit hole.
So I'm hearing you definitely don't want to lose that last bullet from this charter.
Yeah, and I want to acknowledge that we're talking about a system. What that looks like, we're all going to find out. But I think that needs to stay in there.
Okay. Thank you. Dr. McGough.
Yeah, I just have a question about scope, and sensitive to Aaron's point about how much can we pack in. I think most folks know about 20% of our health is determined by what we do in healthcare, and that the majority is affected by the social determinants of health. Will we be discussing the social determinants in a way that promotes some of those goals?
I'm going to fire this one back at trustee team leader here.
Yes, we will be talking about that.
Okay. Is that one related to your earlier comment, Jane, or I just want to make sure I didn't lose you? Okay. Anyone else? That was a good, robust discussion on our charter. I think my takeaways here, and I'm going to turn to my team over here to see if I missed anything, but in terms of the takeaways, we need to do a little bit of work on the language introducing the charge to clarify that these are all issues that we need to tackle and deliberate on, but in terms of what we can accomplish as a group and the scope, maybe managing expectations or acknowledging that there's certain areas in which it'll be deliberating about, but not necessarily have specific recommendations on. We have some proposed changes on the language we're using around being culturally attuned, and also specifying in our health system actors the tribal health systems as specific and separate actors. And we have to do some work that acknowledges that we're not aiming at one system, that we don't want to assume that we're aiming at one system, but there might be multiple ways to get at this. Did I miss anything that we agreed we would do? How about that? Nothing like a little caffeine before a meeting to help me remember all this. All right. Let's see, I think you guys get an early break. Let's take an early break, because then we're going to be sitting for a couple hours doing presentations. So we've got, can I ask everyone to be back here at 2:20 sharp so we can dive into our presentations? So, as mentioned earlier, we do not have our projector working. So Tamara, our wonderful project manager, printed copies so that folks in the audience, we had printed copies already for our folks around the table. Tamara printed copies for our folks in the audience, so appreciative. We're going to be, I'm going to ask the project team to help me get these handed out. But before we start that, we want to make sure we're all using the same vocabulary, and I know just even from the initial one-on-ones and all of the reports that I've been reading to get up to speed on this topic over the last few months, that there are multiple ways of defining some of these terms. So we're going to hand out a glossary. This is the glossary. Health Management Associates created this glossary for us. This is the glossary we're going to be using for these deliberations. I'm sure, I can almost guarantee that some of you are going to look at this and there's going to be words and you're going to say, that's not how I define it. And I understand and appreciate that. We had to throw a dart at the board and pick a definition. So some of these, you might be using the words a little bit differently than you have in the past, but I do want to make sure that we're all using the same vocabulary. The other point I wanted to make is one of the things that excited me so much about facilitating this group is the diversity of lived and work experiences that are around the table. That's extraordinary to me. We have people with MDs, people who went to nursing school, people who've been in the business world for decades, people who have been purchasing healthcare on the exchange for many decades, and people who work in community-based health and have been doing that for a long time. In every one of our industries, there's going to be terms of art, there's going to be jargon and acronyms, and it's really helpful to have those terms of art and jargon and acronyms because it allows us to speak pretty quickly to one another and understand what we're saying. But when we're in this larger group where there's this diversity of perspectives and the benefit of our public and community members listening to our deliberations, it makes that a little more challenging. So I am going to ask folks to do your best to use language that is more accessible to people who are not in your industry. thinking in terms of like speaking with your neighbor about what you do or a friend about what you do who's not in your industry. I know that sometimes we might get off on that, and I, as the facilitators, I'm going to ask to steer you back when that happens. And that is, again, for the benefit of all the other folks that are wanting to listen and understand what you have to say. So with that, I'm going to hand out this glossary here. So in front of you, you should now, or you should be shortly getting the glossary and 2 presentations. We're going to start with Nora Leibowitz, who's going to walk you through the landscape of healthcare delivery in Washington as it stands today. And then we'll move on to WISIP's presentation. I'm going to kind of put some guidelines. I know that you're probably going to have questions or comments as Nora works through her presentation. The rhythm, the cadence that I'd like to establish here is, especially given that some of your questions might be answered later on in her presentation, I'm going to ask you to hold your questions. Nora's going to work in some pauses after she finishes a major topic area, and then we'll stop and I'll say, are there any questions or comments at this point before we move on? So you won't have to wait too long. You won't have to try to remember that question for too long, but I am going to ask you to wait until we get to that pause, and then you can turn your table tent up on its side if you have a question or comment. Does that work for you, Nora? Okay, I'm going to turn this over to you.
Great. In thinking about the intense knowledge in the room and the diversity of experience, as I listened to everyone talk, I had a little bit of a moment where I just wanted to like throw the whole thing out. And that's by way of saying that if there are things that seem super basic to you, just hopefully that thing will be useful for someone in the room, and hopefully there will be something in here that will be new to you or interesting or anyway. So this is really a presentation about where folks in Washington get their coverage. And even that is not a simply answered question, hence the 5 million slides. But it is really primarily focused on coverage. And so I'm the person in the corner who's just talking to herself about coverage. And that then leads us to talk about some related issues. So you'll see some side notes, particularly around the Medicaid program or other things that are happening. But it is primarily focused on coverage. And that's going to include kind of what are the requirements around the Affordable Care Act for individuals in small group? How are things like behavioral health and oral health handled by different markets? And then I'm going to talk really briefly about some of the state efforts that have been going on in the recent years on universal coverage, and then some topics that are related to but not themselves about coverage that I know are on top of mind for many folks. So I'm going to start by talking about the multiple ways that people get coverage, and then I'll give you a little picture of how many people kind of fall into all of these different categories. So one of the major ways that folks get coverage in Washington is Apple Health. And so for each of these, I've sort of identified as like, what the heck is it, and how is it funded, and who is it covering, and all that. So we'll kind of go through that. And Apple Health is Washington's Medicaid program, which has historically covered children and parents and folks with disabilities. And then under the ACA has also grown to cover other adults up to 138% of the federal poverty level, which the FPL is something that's used to determine eligibility for programs, both healthcare programs and other programs. And so just to give you a sense of what 138 means, that's about $35,000 for a family of 4 for a year. So we're not talking about folks who are really living it up, but it is a large number of working families. So, And then additional adults get covered because they have high medical need, because they have a disability, because of pregnancy, et cetera. So in the state, over 1 million people, 117,576 people on average per month are covered by Apple Health. And it's really a comprehensive program, including dental and a whole range of services, the details of which I am blissfully not going to read to you because you would all fall asleep. And then this is a program that's administered by Washington's Healthcare Authority and is primarily delivered by managed care organizations in the state. Some folks do get coverage on a fee-for-service basis where they go to see a provider and the payments are just done directly. But for the most part, people are members of health plans that are administering the care for folks. And then the funding for the Medicaid program in Washington, as it is in states across the country, is a partnership, rather, of the federal government and the state government. So depending on the population that's covered, a minimum of half of the costs are paid for by the federal government and the other half by the state. And then for some kids coverage and for the adults who got covered under the ACA, the part that the feds pay is higher. Yes, and now we're moving to the slide with a picture of Washington on it that says Healthier Washington, Accountable Communities of Health. So this is this is the first example of the accountable communities of health are not themselves a coverage program, but because this is an important program that's been going on the last couple of years that's related to the Medicaid program, we just wanted to do a quick what the heck is an accountable community of health and why should you care kind of thing. So over the last couple of years, the Healthcare Authority has worked with 9 organizations across the state, and you can see on the little map where they are and what they are. And the idea is to think more holistically about healthcare, and that includes wellness, that includes thinking of the whole person in the care. And you can see below the ACH goals, including promoting health equity, creating and supporting and collaborating on local health management plans, thinking about both local and statewide efforts to change how services are provided and how we pay for them, particularly thinking about paying for value, not just paying by each procedure. And then thinking about ways to align resources and activities and with the goal of whole person health. And I think the key thing is that each ACH has the ability to define its own projects, to identify in its community what are the important things to work on. There are some similarities across the different organizations, but they kind of get to define those projects and engage stakeholders at the local level, and with that overall goal of enhancing value-based payment, particularly in the Medicaid program. So, and I'm sure Sue would love to answer all of your ACH questions, so everybody can form a line later. Yes. 1.9 million, sorry. Right. I apologize to that 0.8 million people. So a large number of folks are getting coverage through the Medicaid program, through Apple Health. Individuals who are not eligible for the Medicaid program and generally not being offered coverage in other ways through their employer or through Medicare, et cetera, have the opportunity to buy in the individual market. And this means individuals and families that are buying their own coverage are coming in and saying, okay, I'm gonna look for coverage just for my family. And there are no restrictions. There's no restriction on buying the coverage, but as it notes, most people who have another option, like through an employer, et cetera, are doing that, with some caveats about affordability, et cetera. So in Washington, 441,000 people are getting individual plans. And there are 11 health insurance issuers in the state. And I'll talk a little bit about the health benefit exchange. Some of them participate both in and off the health benefit exchange, others only on and others only off. And then Washington's Office of the Insurance Commissioner plays a role looking at the rates on an annual basis and making sure that they're justified, so that when there are changes in the rates that somebody is paying attention to that. In general, when people are buying their own plans, they are paying for their own plans, with the note that folks who are eligible for tax credits and other financial assistance when they buy through the exchange are able to get federal assistance paying for their plans. And we'll talk a little bit about that in a sec.
Can I ask a question, please? Sorry, I've had it up.
Oh, yes. Sorry. Is a question about individual coverage?
The numbers. Yeah.
About the numbers?
I just want to see if we can get a breakdown of the numbers of people on exchange and off exchange, because that's a
yes, I'm getting to that.
Thank you.
Yeah, and some of it, and some of the problem is depending on the year that you take the data from and what data source. So yeah. Yeah. And of course, I don't have my electronic version right in front of me to look at where I got the data from, but I have little notes to myself, so we can follow up. So I just wanted to note two things that are coming both starting next year and then starting in 2021. For 2020, legislation that was passed about balance billing and sometimes called surprise billing for care that's not covered by people's insurance. Consumers will have additional protections against balance billing starting next year in 2020. And then the other piece is that health plans will be required to offer what are called standardized plans, where the benefits all look the same and the way the cost sharing happens all looks the same, so that people can make apples to apples comparisons between plans. And then that's going to happen in 2021, along with the starting of a public option plan that'll be offered to individual consumers. And it's anyway, so I want to do one quick, on the next slide, I want to quickly talk a little bit about the exchange. You can throw things at me if I get other things wrong about the exchange. But because this is part of how people buy individual coverage in Washington, I wanted to talk really quickly about it. So part of the Affordable Care Act was the establishment of health insurance exchanges, and Washington is one of the states that decided to set up its own health insurance exchange instead of allowing the federal government to run it for it, basically. And the idea is that you can buy individual coverage through the exchange or outside of the exchange, but if you want to determine your eligibility for financial assistance, both federal tax credits to help pay for premiums, as well as help paying for cost sharing when you're going to the doctor, co-pays and that kind of thing, deductibles, that the health insurance exchange is the place that you go to get that eligibility determination and to enroll in coverage with that assistance. So just really quickly, anyone under 65 can get coverage. Eligibility for tax credits is dependent both on your income and the cost of the plans in your area, as well as whether or not you have access to other coverage. So if you have access to affordable employer coverage, then you may not have eligibility for tax credits. And there's a very complicated math equation, which I definitely was going to put up here and make you all solve for to figure that out. But most importantly, I think it's worth noting that it is income-based. And then in Washington, and you can tell me whether or not I have this number correct or not, about 72% of people who are enrolling through the exchange are getting tax credits or financial assistance. Okay. I took this information from last year's CMS public use file, so it may be out of date. Yeah. Yeah. I mean, it's, and it does, the variation in how many people are getting assistance through the exchange, buying their, to pay for premiums, really depends on the income, overall income of folks in the state, the availability of affordable employer coverage. I just spoke with the folks from the Washington, D.C. exchange who have very few people enrolling with tax credits, and it's mostly because there are a ton of young people who are enrolling, and the level of like folks who are lobbyists making a good salary versus low-income folks in the tax credit range is very different from the rest of the United States. So,
Nora?
Yes.
I just have a point of clarification. So on this page, it basically implies that all Washington residents are eligible if they meet these criteria.
That is not my intent.
Okay.
My intent is that, so there are rules around buying what's called a qualified health plan through the exchange based on age. There are eligibility requirements about getting financial assistance that are based on, are you eligible for the Medicaid program? Are you eligible for Medicare? Are you eligible for other federal coverage, public coverage? Are you eligible for employer affordable public provider coverage? But you can see there, that's a lot of words. So yeah, so I don't mean to imply that everybody is eligible, but it is. It's a significant portion of people who are buying individual coverage are going through the exchange.
Yeah, there are two groups that I hear quite a lot about that don't fit into any of these categories. Those are certain immigrant residents of Washington State and folks who fall into what we call the family loophole category. And so many of those folks make up our uninsured, totally uninsured population.
Yeah, and for the, I've heard it called the family glitch. That there are people for whom, to further clarify, there are people for whom their employer-sponsored health coverage is considered affordable in terms of how the ACA defines it, but in real terms is not affordable, and because of the way the regulations are written and have been interpreted, they're not allowed. And this is not just a Washington problem, but a national problem, yeah. Yes, exactly.
Yeah, I'm still curious just to see because, I see the breakout here of the number of individuals enrolled through the exchange compared to 411,000 on the individual market overall, or 441,000. Like, is that really, yeah, thank you, Jane. Like that there are more people off the exchange than on. Thank you.
Can I respond? So overall, the individual market right now is probably somewhere between about 260,000 and 300,000 folks. On average, right now, and Christine can keep me honest, about 80% of the folks in Washington State who are purchasing individual health insurance are purchasing it on the exchange, which I think is a number of carriers only offer coverage on the exchange, et cetera, et cetera. And then overall, in terms of the entire individual market, about half of the folks are receiving a subsidy and half of the folks aren't.
Hello. For individual, how are you calculating or incorporating all those individuals and families buying COBRA? Because in effect, they are individuals buying health insurance with no subsidy.
COBRA is not part of individual coverage for the counts
Right.
included here. That those numbers came, the overall ones that we'll get to in a couple of slides that show the breakout, that those came from the Kaiser Family Foundation, and they noted that they include in the group coverage, getting your coverage in this ex-employer way. So.
Oh, okay. But it's important to note that people are paying full price.
Sure. Yeah,
and
yeah.
not subsidized.
Right.
But they're comparing COBRA to the exchanges and making decisions.
COBRA, COBRA is a unique group, different from employer coverage and from individual
They
market.
could look like employer coverage, and they're not actually.
Yeah. Okay. That's. Do we have other? Yes.
Yeah, I think that is an important distinction. You know, in COBRA, people are paying the full premium for that coverage, but they're buying it through, you know, their employer is being offered that way. In addition, there are employers who, you know, maybe dependents are paying, you know, they're paying full price. Their premium's not being subsidized either through that group health plan, through that employer health plan. So it's important to recognize that as well.
Right. And that's part of, I mean, that I think that's is a key issue here is that this information is not intended to say this type of coverage is better than that type of coverage, or these people are paying less or more, because there are people who work for employers where the employer pays the entire amount. There are employers where the employer pays a minimal amount, nothing, you know, there are people who are getting significant tax credits, people who are paying the full amount. So I think these issues, I appreciate you noting them, because they're in each type of coverage, there's not an implication that it's somehow the end-all be-all.
I'll just make a quick note too, because I think what I'm hearing is in the context of affordability, we need to consider folks on COBRA, folks who are paying for the pocket.
Well, being a COBRA person now, I can tell you that the premiums are roughly half of what they will be when I'm on the exchange. I just got to wonder, you know, you see all this data from the Kaiser Family Foundation, CMS, from the Insurance Commissioner, the exchange. They all seem different. And there's been reports recently that at least the unsubsidized part of the exchange, particularly in Washington State, is dramatically decreasing, probably because of cost. This committee should be able to have a source of data that's reliable, I would think. I mean, with all these people sitting around. And in particular, the cost of exchange plans. I went in and I sent you, you know, what my options are in the exchange, and they suck. I mean, I don't know how else to describe it. And they're limited network. They're extremely expensive. And when I get travel out of the state, I'm out of network. So the out-of-pocket costs is roughly 10 times more, because that's what hospitals do. They charge 10 times what they expect to get. So we need at least to have some idea of the magnitude of the problem in our state, and among this body, we should be able to get good data.
So I want to capture a couple of things that there's a lot of variation. Oh, thank you. A lot of variation in the data we're seeing, which tells us something, and we need to be able to nail that down so we can do our deliberations. And then the other thing you mentioned was specific to, but probably encompassing, getting a handle on all of the problems. I think this gets back to Don's earlier point too, all of the problems that we're dealing with healthcare. You've just experienced it yourself, what you saw in the healthcare exchange. Do we have any? Oh, yes, Dr. Kovar. Oh, sorry, no, not you. Kirsten, I apologize. I'm not wearing my glasses.
It's late on Friday as well, but I think to also to include in the discussion about premium costs, let's not forget deductibles and co-pays, because the deductibles are horrendous as well for people. I'm sure there are a lot of citizens that feel they're paying for nothing unless they're going to be half dead through the year to meet that yearly, and it's a yearly deductible for folks.
Yes, and I think we're going to be, in our next presentation, we're going to be talking a little more about that too. And just to clarify, we're now getting into the context of overall affordability. I think Nora's going to focus us on numbers of
Well, and coverage, yes. And I really do appreciate folks bringing up these issues because that is really the next level of, okay, well, what does it mean to have coverage?
Okay, let's take Evan and then let's move along a little bit.
I just wanted to make a comment that everything that we're hearing right now, this patchwork that we have, for me, is why we're sitting here, so that we can figure out a better system.
Yes. Yeah. Okay, so let's talk a little bit about what the ACA meant for individual and small group markets. We are on slide, well, this says to me 8, but, oh, did I skip I may have skipped small group. I did. Sorry. So, I just wanted to clarify what small group means versus large group, and I'm sure you all understand the word small. So, 1 to 50 employee groups, and this is a market in which the employer gets to make a decision in terms of how expansive the benefit package is. Obviously, they need to fit. We're going to talk about essential health benefits, but within reason, they get to decide what coverage looks like, and how much employees pay, how much families pay. As was noted earlier, often it's different. The employer will often offer employees to pay much more of the costs through the employer, and then if you want to add your families, often the cost is increased. Now, of course, I'm questioning every number on this document, but what I got from the insurance division was that about 30% of firms with fewer than 50 employees are offering coverage. And I think one of the things that is conceptually challenging for me is small employers are small, right? So the total number of people is lower, but there are many small employers in Washington. So even though the total number of people that we may be talking about is not humongous, it's a lot of businesses and it really affects a lot of people. So again, there are 12 insurers in this market, and the Office of the Insurance Commissioner is regulating this market as well as individual. And then, as I noted, the funding depends on how the employer sets it up and the options that they've chosen. So on slide 8, I just wanted to talk really quickly about some of the operating rules under the ACA, because a number of things did change with the Affordable Care Act for individual and small group markets. The top one is in the box is that there are 10 categories of care, the essential health benefits, and these are categories of care that need to be covered. And that for those sets of services, you can't have pre-existing condition exclusions. That the benefits, that getting access to the benefits is guaranteed for the consumer, and without regard to folks' comments about getting those services. In reality, they need to be covered in the plan. And that getting that coverage, you cannot be denied for current or past healthcare needs. So unlike before, in many states across the country, before the Affordable Care Act, you would go and apply for coverage, and if you had a medical issue now, or you had one in the past, you could get denied. You could get denied coverage. Particularly, it was an issue in the individual market, and now insurers can't do that. That was part of the trade-off with having it be an individual mandate. Was the idea was to get everybody in the pool now that everybody could get in the pool. So there are a number of other things like the young adults up to age 25 being on parents' plans, which is apparently one of the most popular items in the ACA, except for the parents who are trying to get their children out of their houses. there's also a number of preventative services that have to be available without individual cost sharing, consumer cost sharing, and that there can't be annual or lifetime limits on essential health benefits. So if a health plan has coverage for items that are not considered essential health benefits, they can have limits, but for this set of 10 categories of care, it's not allowed. There are plans that are called grandfathered plans. They existed on or before March 23rd of 2010. They can exist and continue having enrollment even under the ACA. They can kind of skirt by some of these requirements, but in Washington, there are relatively few people, estimated 6,000 to 8,000 people who are still on those plans. There are some states in which this is a much bigger portion of the population, but not surprisingly, Washington kind of got on board with, we like these protections. So before I move on, any questions about, because the ACA is super easy and non-complex, so I'm sure there's no questions there about that. Okay.
Will there be time to talk about the new regulations from Trump that are going to take place that will increase premiums in 2020 and also degrade health insurance for everyone in the country? Will we be talking about that at some point?
I have lots to say about those things. Okay. We're not going to talk so much about it today, but I think the issues about how Washington wants to set up its healthcare rules in light of larger federal changes is really part of the discussion.
Great, thank you.
The note I'll make, Kelly, because I think that's, to what Nora just said, part of the bigger question of all of the federal challenges or obstacles we face. Maybe we can write down that we need to do a deeper dive into that at a subsequent meeting.
Excellent.
Anything else?
Okay, I realize I'm taking too much time. So I'm going to talk faster or something. So large group insurance, the really key thing here is that again, like small employers, the employers are deciding what some of the parameters of the coverage. There are over 1 million people covered in large group coverage, not surprisingly, because large groups are large. And that employers have the option to either buy traditional insurance, which is to say that they are paying premiums and the insurance company is taking on the risk of providing the care. Many large employers have chosen to do what's called self-insure, where they say, we're going to take on the risk, and they do that because they are a very large employer and think that, I could have some sick employees and some healthy employees and it'll all work out. And actually that trend is moving into smaller and smaller groups, which is kind of a side note, but interesting in terms of people's willingness to take on risk in order to save money. I don't get into a lot on Taft-Hartley or other group purchasing, but I just wanted to note that there are, and it did come up a little bit earlier, but there are ways of employers getting together to offer coverage to their employees kind of by banding together through things called association health plans and Taft-Hartley Trust, et cetera. So what else do I want to note about that? I think for the moment we'll just...
Hey, Nora?
Yes. This room is like a giant echo chamber, so I never know where to look.
So Nora, to confirm, within this large group category, you're including both the Erisa and non-Erisa plans. I think you're alluding to that when you talked about Taft-Hartley. So maybe you can talk a little bit about Erisa, just on a very high level, because to me it's relevant in terms of what the OIC, our Office of Insurance Commissioner, has jurisdiction over and what we don't at the state level.
Yes.
And then secondly, are you including the public employee plans, both state, federal, and local public employee plans under large group?
Yes. To answer the easier part first. Okay, so Erisa, which is quite expansive and bigger than healthcare, but from a healthcare standpoint, is important to note that Erisa sets requirements that limit what government can tell large employers, some large employers, that they need to do in terms of their coverage or how they deal with their health coverage. This is the kind of thing that my brain is churning on, like how to explain this in a way that's not going to take up a lot of time, because it's quite a complex thing. But I think it's worth, I appreciate it because I think it's worth noting that Erisa, which has been around since the early 70s, has in some cases been a barrier to making universal coverage changes, because large employers will stand up and say, you can't tell me what to do in this area because of Erisa. And basically only one state has a waiver of Erisa, and that's Hawaii. Hawaii has a waiver which allows them to tell all employers, you have to fund coverage for your employees. And then they got a waiver because the Hawaii coverage requirement existed before Erisa existed. So in terms of one of the many barriers to any kind of universal coverage requirement, Erisa is one of those mountains. So.
Thanks very much. I know we've already mentioned that there's going to be some review of these numbers done. It might be helpful to talk to the OIC here rather than relying on NAIC for some of those counts. And in particular, I think it's important, given the historical enrollment in association health plans, for us maybe to get a better sense of who's actually in there, because just looking at slide number 9, one might think that association plans are composed of employer groups of 51 and above, and that's absolutely not the case.
Yeah, sorry.
In fact, our small group market, I think the numbers are inflated because most of our small group offerings are actually through association plans, I believe. So a breakdown of that, and similar to what Representative Macri said, getting a better sense of how PEB and SEB enrollment breaks out as part of that might be helpful too, for us to be able to see the funding sources, those that are actually private sector employer funded versus public sector and taxpayer subsidized.
Sure. Thanks.
I'm hearing, Patrick, you'd like to get better and clearer breakdown of those numbers. You mentioned smaller employers with private association plans. Using the Office of the Insurance Commissioner in this state for these numbers, where you think we might get a better count there. That's what yeah. So, yeah, I've heard that a couple times already. Just right. Kelly? Oh, is that on? Okay. Dr. Turco?
I think I may be asking the same question, but clearly, Erisa, we can't tell the self-insured plans what to do. What I'm wondering is, since almost all of them uses a regulated entity to administer the plan, can we at least find out what they are doing as opposed to telling them what to do? Because they may be running really good health plans that are very large, and we could learn something.
So your seatmate was just shaking her head to the, can we tell what they're doing? Yeah, which is my understanding as well.
Okay. So Washington State does, first of all, under federal law, we cannot regulate self-funded group health plans. Some states regulate the third-party administrators who operate those plans. Washington State does not. So, and if people remember, I'm going to sound wonky, but if people remember the Gobey decision, which the United States Supreme Court issued a few years ago, which said that Vermont can't require self-funded group health plans to dump data into their all-payer claims database, the issue that the court raised with that was that the state was trying to regulate sort of any aspect of administration. So I think it might even be a stretch for a state, it probably would be a big stretch for a state to say we want self-funded group health plans to even report basic data to the state. And the keeper of data about self-funded group health plans is essentially the United States Department of Labor.
Related to that, I was hopeful and curious if there is a way to get numbers on self-funded employers in Washington State, but it sounds like we have to ask DOL.
So the way most people compute that is by backing into it. So Aaron's shaking, yes. Okay. So basically it's like we know the population of the state, we know Medicaid, we know Medicare, we know the fully insured market. So I would say at this point, when we've done backing into it methodology, it's probably a couple of million folks that are covered through self-funded group health plans. And a big chunk of those folks are uniform medical plan for state employees, and there are some big governmental association health plans like the Association of Washington Cities that have a lot of enrollees. So we back into it, basically.
So I'm understanding we have to do some work around the data.
Yep. Okay. We're happy to help.
But we will need to get to the point where we're drawing on a lot of the expertise around the table to make that happen.
Yeah, so I just reiterate Jane's point here about how to actually back into that data. But at the Association of Washington Health Plans, our members serve as a lot of times as those third-party administrators for those self-funded plans. So if the group here wanted to hear from one of those entities about how we do that, I mean, you could simply invite one of us to do that, and we'd be happy to.
I'm going to take our chair, and then just a time check for you. You have till 3:30, so you're okay. You're not running away over there.
Yes. And I want to note that while we can't necessarily regulate, there is a very strong alliance of sharing that's going on through the Washington Health Alliance that is a very open sharing forum where a lot of this data aggregation and whatnot is occurring. So we have other ways in this state where we really are aligning and capturing other bits of data.
Okay, I think we can move on.
Okay. So now I want to talk a little bit about the Medicare program, which is primarily covering folks who are 65 and above, but also enrolls individuals who are under that age who have a permanent disability. That's about 14% of the population in Washington. Medicare is younger than 65. We had some discussion about how much detail to go into Medicare because it has lots of different parts with different meaning. So again, forgive me for kind of doing a top level discussion, but so the basic pieces of Medicare are Medicare Part A and Medicare Part B. A is hospital care, and B is other medical coverage. That includes doctor visits, outpatient, et cetera. And if you are an enrollee, you can get A and or B on a fee-for-service basis, where you find a provider who will take Medicare, and you go and see them, and then you and Medicare pay that provider. You also can go instead to join Medicare Advantage, which basically those are health plans that are administering the plan, and they are generally they're private insurers, and they are providing A and B benefits. Often they offer additional benefits on top of that, partially to encourage people to enroll with them. And just as a note, 30 of the state's 39 counties have offerings for Medicare Advantage. So there are a number of counties where it's just not a possibility, and so people do traditional Medicare. And then just to round out the alphabet soup, there is Part D, which is the prescription drug coverage. Because for most of Medicare's history, prescription drugs outside of the hospital were not part of the covered benefits. So Part D was instituted and now offers that coverage assistance for prescription drugs, which obviously for the over 65 population becomes more of an issue. So over 1.3 million people are covered in Washington in 2018. That's the most recent numbers I had. And about a third of those people are in Medicare Advantage plans. So it's interesting to note that that not quite 1 million people have Part D coverage, and people's needs obviously are dependent, and having gone with some relatives through the process of what is the right way of getting Medicare coverage, there are a number of factors that people put into their calculations outside of the traditional Medicare program, but also offered to people with Medicare, are these supplemental, often called Medigap programs, and those are programs that offer assistance with paying for the portion of coverage that individuals are responsible for. So these are all kind of the fun terms for Medicare. And then the federal government pays for a portion of Medicare, and the consumer pays as well. And then depending on whether people are going to fee-for-service traditional Medicare or going through a Medicare Advantage plan, the administration varies. Yes.
Do we have any statistics on what the cost shifting that goes through the system from uninsured people and how many uninsured people there are? I know at our clinic, about 17% of we've been averaging the last year has been uninsured patients. And one of the significant things is they're usually much more complex problems because they've delayed health care. Even before Obamacare, just to give you an idea, we were running 40% uninsured. Do we have, I don't see any statistics on what the costs are to run those through the system, and then also what percentage of people are uninsured.
So I do get to the uninsured piece. This presentation doesn't include the cost shifting, but I think what you're raising is a key point about the fact that depending on what kind of coverage you have, the reimbursement to providers differs. So the Medicaid program, Medicare, tend to pay at differential levels compared to commercial coverage. So yeah, and sure, yeah. But that is not included in this, but it is part of an ongoing, yeah.
So I'm hearing then, and tell me if I have this right, that there's interest in, first of all, understanding the proportion of uninsured that are getting care under here, and then getting some rough estimates or better on how those costs are being absorbed elsewhere, and who's absorbing them and how they're being absorbed. Okay.
Nice, easy questions. At least I can answer the numbers, the uninsured question. So, okay. I wanted to round out the coverage discussion by talking a little bit about TRICARE, which. Sorry, can I interrupt you 1 second? Yes. Oh, sorry.
I just wanted to add to that request. I think it's important too, because I think it might help with identifying possible funding sources. If we can start identify where in the state is this cost picked up for not just uninsured people, but also underinsured.
So folks who are active duty military, retirees, family, use coverage through the federal government. The TRICARE program, which used to be called Champus, is for uniform service members, retirees, and their families. And TRICARE does have, in addition to medical plans, it also has some other special programs. It has prescription coverage, has dental plans. The coverage in Washington is roughly 350,000 folks are covered. Both the consumer and the federal government help pay for it. And how much the feds pay for it depends on the individual's status. Are they active duty, or are they retiree, family member, what's their rank, et cetera. And then it's administered by the Federal Department of Defense. It has a number of options depending on the location, including managed care, fee-for-service, preferred provider organizations. And then it also does some Medicare wraparound. So for folks that have aged into the Medicare program, they provide kind of a additional assistance. Awesome. Okay. So I can at least answer the Don's question about uninsured by moving on to the slide that includes the coverage landscape and is a little gray table. Again, it sounds like my numbers are out of date for the individual coverage, but this will give you kind of a general sense of the coverage landscape, including, I think, noting how many people in the state get coverage through an employer, either a small employer or a large employer, because often we talk a lot about folks who are in one way or another responding to the rules under the ACA and trying to get coverage or struggling with coverage. And then we also talk about the public programs. But I wanted to identify that from a numbers perspective, there are really a lot of folks who are getting employer coverage. So we want to make sure that we're thinking about the range of coverage within the state. So including the uninsured and the insured. Maybe let's just do one more slide and then we can, so the related next slide just gives you a sense really quickly about how things have changed a little bit from before the ACA in 2013 to 2017. And then looking, because these are the numbers that allowed me to do a US Washington coverage, I used 2017, give you some sense of what things look like in Washington versus the US as a whole. And they're not, super inconsistent, but you can see that when Washington expanded its Medicaid program under the ACA, that significantly increased the number of people who were getting coverage through that program. And it didn't, there were a lot of people who were waving their hands about the fact that these folks were going to come from the individual market, or they were going to come from employer coverage, and that we were going to be using government funds to subsidize people who already had coverage. But for the most part, it really did come from the uninsured. And you can see the drop in uninsured from before the ACA to now, or at least a couple of years ago. And also in terms of the one little bright spot in thinking about all of the problems and issues with healthcare, you can say, oh, Washington is doing slightly better than the nation in terms of the number of uninsured.
Okay, so we'll start with Aaron. I think you were the first one up.
So I want to echo points that Aaron and Kirsten made earlier, that in this coverage picture, you haven't mentioned Indian Health Service or the tribal health systems. And they're important not only because of the numbers, but a number of the tribes, particularly the Jamestown, S'Klallam, and Colvilles, have developed health systems that attempt to wrap around a number of these coverage programs and includes and provide services beyond tribal members. And so they offer models, I think, that we will want to look at in the next few months.
It's a really good point. We kind of struggled with how to talk about IHS because we didn't want to imply that folks who are eligible for services through the Indian Health Service were somehow not eligible for other programs. And because there are a number of folks who are using the Medicaid program, who are using employer-based coverage, et cetera, and that particularly because in addition to tribes with really fantastic models and a financial ability to provide a lot of services, there are people who are reliant on IHS in areas where the tribe doesn't have a ton of money, and that impacts people's access to coverage. So we didn't want to I was a little concerned about suggesting, oh, well, we don't have to worry about American Indians and Alaska Natives because they have this thing, but I really appreciate your bringing up the models.
Of course, we could say the same about people who have coverage on the individual, on the exchange who are paying $5,000 deductibles.
Yeah.
Right, so.
Yeah.
Yes, really quickly, I would like us to include the underinsured as a terminology in the glossary so that we all could get our handle on what that means. And then also, is there a way to include that in your numbers here? Can we get some numbers on the underinsured in Washington State?
I think first we will work on the definition piece. My heart started beating fast about the idea of trying to define it, just because I think it's going to be really challenging I think it's worthwhile to define it, and I'm not sure how to wrap my head around pulling those people out of the other numbers.
Is it possible we don't have to pull them out, but just say we think this many people are underinsured, so it's not a separate category per se?
So, Kelly, Nora and I had this discussion over email actually a couple of weeks ago when she was preparing this, because I had also heard from a few of you that underinsured was really important, and she said it is really important. It's also really hard to pull those numbers together. When we start, I've been thinking about this a lot, when we start talking about the principles of a healthcare system that healthcare coverage, healthcare provision. When we start talking about that, I think we can start to dive into who that leaves out, and who's underinsured. But I think the bigger point here is that I've heard that underinsured, there's not a clear definition we can pop in the glossary. We're going to have to do some work as a group probably on that. I think Dr. Trick goes next.
As far as uninsured, I realize this comes from census data, but if you match it to Washington exchange data, you may find that the vast majority of these people actually qualify for Medicaid but don't enroll.
Okay. That's a comment to note.
Yeah, okay. Okay, I am getting close to the end, I promise.
I want to make sure that I take all the questions that are up, so let's get through those, and then we'll see where we are and if there's any that we can skip over.
Yeah, I think we're gonna skip the pie chart just because it's gonna take some explaining, and let's.
Okay, let me do this good. I think Lisa was next.
Hopefully this is a very quick question. So for the Medicaid numbers, does that include just full scope Medicaid, or does it also include some of those limited programs like pregnancy medical, family planning, or is it just full scope?
My understanding, I'll double check, but my understanding is it includes those programs as well.
So I think, I know you guys did a lot of work, so I feel a little bit bad that we're nitpicking the data so much, but we do have a really great resource in the Insurance Commissioner's Office. So I think when the numbers get updated, it'd be really important to have these percentages updated, because, as we identified, the number for the individual markets off a bit, and it's important for us to understand where these breakouts are. So just a request. The other thing is a question about the individual market on this pre-ACA, post-ACA. I don't understand how there was 6% in the individual market before the ACA, because we didn't have much of an individual market before the ACA.
It'll be part of my,
Okay.
We'll go and look.
I guess for me, I kind of wanted to reiterate this kind of underinsured perspective, because it's much like we look at the unemployment levels, right? The folks who have just given up looking for work, or, I think it's really important to capture this somehow, some way, especially if we're looking at an econometric analysis where we're going to look at costs and savings, I hope, to individuals in the state. So understanding our base, I think, is really, really critical in being able to accurately reflect costs and savings both to individuals in the state.
And definitely very strong opinion from many of you that we need to get ahead of what underinsured is and how much people that's going to be a
So I just want to bring up that the IHS is not insurance. So that's the most important piece of this, is that even if you have the IHS, so that's a payer of last resort. Right. So anybody who's in there, our numbers are going to reflect in the uninsured population in some form or fashion. But anytime that we are covered, it's within the existing markets. Mm-hmm. So that's the way that works, and our numbers are going to be skewed. And also understanding that our ITU system of care, which is the IHS Direct, Tribal 638, and Urban Indian Health Program, every single payer model that you looked at in coverage model, we deal with every single one of them. Right. So if there is a universal health care model right now, that's what we're operating under, and we have been for a very long time. So looking to that system and understanding it really well is going to inform the process that we're going through right now. And I really, really encourage looking at the American Indian Health Commission of Washington State, which has this all laid out in very much the fashion that you're looking at it right now, with the numbers that we have access to.
Yeah. I think you brought up, I just wanted to reiterate what you just said about the fact that IHS can bill all of these payers. And so, right. Right. That I mean that having access to IHS, as you note, is not a coverage type, but that going to providers, those providers, if the person has X, Y, or Z coverage, they can bill those as part of the program.
Right. And then also understanding we're the only population that can opt in and out of care, managed care on the monthly.
Mm-hmm. Okay, I'm being really mindful of time because I want to make sure we have time for the rest of the presentation. We have a couple more comments. If you're echoing someone else's comments, if you could just say it really quickly, let me know that. Then we can move through because I know we've got a couple more slides from Nora. I think
I just hope it's a request for a lot more drill down data about the uninsured issue. If we weren't looking at that in detail, I don't know that we would be here in this entire process. That's really what's driving this, fundamentally, the problem that we have to solve, along with the underinsured. I appreciated Don pointing out that in Yakima they went from 40% to 14% uninsured. My urban disaster world here went from about 55% down to about 21. This is a very dramatic problem. I appreciate Representative Macri pointing out that the constituents she hears from are immigrants. She hears from them all the time. So when we talk about the uninsured, it's really important to call out the agony of the immigrant in our communities, and not to have some kind of lump number here. It's really important that we understand that these are refugees who have a woefully short period of time on public benefits. There are asylum seekers who are incredibly invisible, maybe a little more in the last couple of months, and then we're looking at the rest of immigrant populations who, it's very important to understand that these are populations that can't participate in coverage systems if they've been here for less than 5 years, can't buy into the exchange, et cetera. So this is a very, very dramatic problem. It's a disproportionate share of this. I don't think that we're looking at an issue of people. We've gone through this, have scoured the state multiple times looking for people who are eligible and signed them up. That's not the problem anymore. And these disproportionate, this is a huge piece that we need to understand in great detail to come up with solutions, because it's going to involve all kinds of outreach, communication, public health efforts, et cetera. So, and I'm really only bringing that because it's got to be more than a footnote on the last page.
So I'm going to summarize what I've heard this from a number of you, and I appreciate the level of interest and importance that this particular issue has, that we need to not only understand numbers on uninsured and underinsured, but we're looking for some drill down to who those people are and why they're falling into that. Or left out, so why they're falling into that. So we are making note. You also just made a point that that's going to take what I might describe as a very large effort to really get to do that. So I'm also just being mindful of the scope of resources that we have to do that. But it is very clear to me that this is important to many of these around the folks, and also that's not it. We need to move on, so I'm going to really quickly get through our last item, and then I have that presentation. So.
And I can be really quick. I just wanted to make sure that to the underinsured, we also add the problem of access to care. Dental is a prime example of that. Just because you have dental coverage in a Medicaid plan doesn't mean you can access it. Same with primary care in the state of Washington. It's a huge issue, and I think we want to be mindful of that as we move forward with this. Just because we might offer insurance and care, does that really mean that people have access to it as well?
Thank you. I know you're not going to talk about this pie chart, but when you do include public employees at all levels of government, I think the number is over 50% of Washingtonians are covered by some taxpayer-funded form of healthcare coverage. So to me, that's significant in part, and I have a recommendation. This also might be very challenging to do, but to analyze this from a different angle, which is healthcare is the second largest area of expense in the state operating budget, second only to K-12 education. And how we spend those dollars and how that impacts these numbers of covered lives, I think would be a helpful thing for us to understand. Because when we're talking about how can the state engage in a universal health care approach, one thing we might want to think about is how much money are we spending now? If we leverage that in a different way, can we find better outcomes for residents in Washington State?
So when you folks do go back and tackle that very difficult issue of trying to define underinsured, I think it would be great to look at individuals who have purchased coverage that is not insurance. There are a lot of products out there like health sharing ministries and some of these other sort of products that are floating around. 100,000 people in the Pacific Northwest have a health sharing ministry plan, and so there are a lot of things like that that people find.
Okay, really quickly, I promise. I just wanted to talk really quickly about two areas. As you all know, there's sort of a tendency to treat this as healthcare and not this as healthcare. And so I just wanted to talk about two areas that hit above the neck, behavioral health and oral health. So really quickly, noting that Washington does have a behavioral health parity law that requires that health plans that are providing medical and surgical services also cover medically necessary mental health services. And that this has been around since 2007. So just giving some little definitions about what is considered medically necessary outpatient and inpatient services. And then just noting that how this works in reality and what the coverage is differs by the market. So in general, commercial coverage includes behavioral health, in part because of this parity law. That Apple Health also now includes fully integrated, the fully integrated managed care plans include both physical health and behavioral health in them. And that Medicare has in Part A and Part B covers both inpatient and non-hospital mental health services. That was super fast. I recognize all of the things that folks said about access to care, about affordability, about, all of these things I recognize apply here, but I'm going to get the hook soon. And then similarly for oral health, just wanted to quickly talk about that in commercial health, oral health is usually not part of your medical plan, except per the HCA that kids medical coverage, kids have to get oral health, and so some health plans will offer it through through the medical plan, but and others it's separate. That Apple Health has carved out Medicaid, and so it's provided directly, not through the managed care plans, but it's a covered service for Apple Health. And then that under Medicare, routine dental care is not part of the coverage, although there are some emergency services that end up getting covered. And that Medicare Advantage, often one of the inducements to enroll in a Medicare Advantage plan is that they'll offer dental coverage. And then I'm not going to talk about the other states. You all can read those. But the last slide, which really is was sort of my recognizing that folks were going to have a lot of really important things to say about, okay, what else besides coverage? There were a number of the topics that folks raised, including thinking about the access that that American Indian and Alaska Natives have, as well as I realize I wrote American Indian anyway. And underinsurance, thinking about costs, both in terms of premium costs on a monthly basis, as well as what people pay out of pocket for care, and the impact that that has on access. Thinking about particular access issues and coverage issues for undocumented and immigrant populations, as well as people without homes. Thinking about other issues around inefficiency in the way care is delivered, the way we pay for care, and obviously the relationship between health and social and economic factors. So there are so many more pieces, and this is really just intended to get at one of them. So I really appreciate all of the really insightful comments that people raised, and I think that's going to be informing our work as we go on.
And you probably can't answer this question, but our system is really based on billing for services within four walls. Do we have some statistics that would really indicate if we paid a different way for, using the telephone, so people don't even really have to come to a healthcare facility, what that would entail, or how many people that could involve? I just don't know if you have. To me, one of the real problems with our present system is we bill for services within the four walls rather than finding a way we can compensate providers if they just have a brief phone conversation, or using some of the things my grandsons know how to use, the YouTube and that kind of stuff.
Yeah, and I have recently read a lot about the increasing popularity of I would call them telehealth, but really it's app-based behavioral health care that particularly for younger people have been using. And so I need to look at what kind of information is available in terms of the financial impact, but certainly there's a lot of information about telehealth and other sort of the impacts of other sites of care, I would say.
Okay, thank you, Nora. There's a lot to put together there, so we appreciate it. So John Bauer with the Washington State Institute of Public Policy is with us today. Hi, come on up. Thank you. So you have in front of you the other slide deck. That's his presentation. Some of you may have actually seen a version of this already. John, the way I've been doing this, you probably noticed, is if you run through a couple slides and you get to a natural pause, then we can take people's questions. So you signal to me when you feel like it's the right time to take a pause. And also, if you could call out the slide number so that people can follow you, that'd be great.
Okay, that's all.
We have between slides and questions and comments till 4:30.
Okay, hello, welcome. Thank you for having me here today. Again, I'm John Bauer from the Washington State Institute for Public Health. The Institute does nonpartisan research for the legislature. Just like to state up front, I'm an economist. I want to apologize for that at the beginning and might explain some of the incoherence in these slides. But on slide 1 is the assignment we were given by the legislature, what we were asked to look at in the reports we prepared over the last year. Basically, what we did, if you look on slide 2, we addressed those components in 2 reports. The first report looked at universal coverage, single-payer health care proposals primarily in the U.S., and studies that tried to assess what impact adopting single-payer coverage would have in the U.S. And then the final report took a more international perspective and looked at different models. It looked at both single-payer and multi-payer models based on with health insurance coverage in European countries, high-income countries. I'll summarize both of these reports, and what I'll do over the next half hour is really try to give a broad discussion of some of these other issues that we were just mentioning earlier. We'll talk about coverage briefly, but then go in to look at costs, and then some access and quality of care issues, and just look at those broadly from the literature that we examined in these international comparisons. If you look at slide, I didn't print this out big enough, slide 3, that's titled Universal Coverage. The first part of our report looked at defining universal coverage. And by universal coverage, it's not just that all residents have health care, but that health care is affordable. You know, they can actually access it without going through financial burden, financial stress. Now, we looked at 10 other high-income countries, primarily in Europe, but also Japan. Among those other countries, each of them has achieved universal coverage. Only the United States doesn't have universal coverage. And these other countries will see achieved universal coverage by 3 things. One, there's a strong mandate to have insurance. Secondly, there's strong subsidies to make it affordable. And thirdly, all insurers have to accept all clients. That's basically how they did it. Some have done it, we'll see, through single-payer systems, which the first part of this talk will address. Others have done it through multi-payer systems. Okay, if you look at slide 5, this is a quick summary of what single-payer healthcare is, just to get us all on the same page. One way to achieve universal coverage is through a single-payer system, although it's not necessary to have a single-payer system to achieve it. Single-payer systems have those 4 main characteristics. First of all, this summarizes what single-payer coverage proposals in the U.S. would have. First of all, because there's a single system, individuals with Medicaid, Medicare, employer-sponsored coverage, individual coverage, and those who are uninsured are automatically covered by one plan. Everyone gets the same thing. Private insurance would be eliminated in most of these proposals, or limited to providing supplemental coverage. Cost sharing would be reduced or eliminated across the board, and premiums would be eliminated. And finally, there would be a single set of payment rates. We talked briefly about payment rates under the current system. Medicaid pays providers much less than Medicare, and commercial pays much more than Medicare. So employers would get the same payment no matter who they served. If you look at the next slide, slide 6, slide 5. In the national debate over single payer, one of the items that gets the most attention, in addition to taxes, is cost savings. How much money would single payer systems save the U.S.? Well, some components of single payer actually increase costs. Other components are likely to decrease costs, so it depends on the relative sizes of those effects. Single-payer coverage would increase cost as proposed in the U.S. by 3 ways. In 3 ways, it would extend coverage to those who are previously uninsured. The uninsured currently get services, but they would get more services if they were insured. Reducing or eliminating cost sharing among enrollees will increase costs because when you completely eliminate cost sharing, people use services more. And then providing more comprehensive benefits, improving access that we were talking about, like providing dental and vision would cost additional funds. So you have those things increasing. On the other hand, single-payer systems would reduce healthcare expenditures by reducing insurer and provider administrative costs, and we'll talk about that in a little bit. It would facilitate negotiated reduction in pharmaceutical prices and other medical fees. And there's the potential for the system to encourage more cost-effective medicine, and we'll come to that again later in the talk. Well, when we look at all the studies that have been done, they make different assumptions about the relative sizes of each of these factors. And because of that, there's a lot of uncertainty and a lot of variation in the estimates. That's the next slide. These are studies that we looked at. What those bars represent is what the study believes would be the ultimate net effect on total healthcare spending if single payer were to be adopted. And you can see there's a wide range of estimates. And in the interim report, there's a lot of detail about the specific assumptions that are generating these different results. And you can look at that. Another area of uncertainty is how long it would take for savings to accrue. You can imagine if single payer were implemented, it might take time for these savings to be generated within the system. The next slide just briefly summarizes the advantages and disadvantages you see in the literature with respect to single payer. The advantages, the advocates say that it'll be more equal and more universal care. Centralized administration would have benefits, and there are potential cost savings. Those opposed to single payer raise concerns about the higher taxes, government control, perhaps rationing of care, and possible underfunding of the system. If we look at slide 7, one big issue, and I apologize if I skipped a slide or went that way. One of the major issues, yeah?
Could you just say the title of the slide while you're going through them instead of the number?
Yeah, because I can't even read the number. That's a good idea. Single payer financing. Okay, let's go there. Thanks so much. One of the big issues, and it's an issue that you see talked about in the press, is the financing of single payer. A rough estimate is that we spend about $55 billion on health care in Washington State, and that's very rough. It's, there have been requests for good data, better data. Healthcare data is very, it's hard to get good data, but this is our best estimate. In 2018, there's about $55 billion spent. About half of that spending was by Medicare and Medicaid, so it was publicly funded. Most of the remainder is through employer-sponsored care. So single-payer funding proposals assume or rely on Medicare and Medicaid funding being channeled to pay for the single-payer plan. And also, then all of the employer-sponsored care, we need to come up with a different way to pay for that. So the employer and employee premiums, individual premiums, and all that cost sharing, which gets eliminated, that has to be funded by tax revenue. And because that spending's so large, well, naturally, taxes would be large. So how health care is paid for under single payer would create some changes that just involve larger taxes. Note that each household, or most households, may ultimately pay less for health care. It's just they're going to pay for it in a different way. Okay, the next slide, which should be 8. Oh, we did that. I did that ahead of time. I spoiled the surprise. Okay. The next one then, implementation challenges, which we talked a little bit about that, slide 9. Again, single-payer proposals rely on using federal funding for Medicare and Medicaid to fund a single-payer proposal in a state, and that's unlikely to occur. That would be a major challenge. The second challenge with respect to funding to implementation is Erisa, which we talked about now. That's the federal law that regulates employee benefits. And as we said before, it really prohibits states from regulating self-insured employer plans, which are a large component of the employer-sponsored care. And so that would be another issue, because it's likely that firms would challenge a single-payer implementation based on Erisa. One of the issues that these large self-funded employers face is that they have employees in multiple states. So that's an issue that might make them challenge Erisa under that. Okay, the next slide. Healthcare comparisons across countries. So we're going to move from single payer to look more broadly at different healthcare models and comparisons of the U.S. with other countries. Yeah.
Sorry, before we move on, I just want to make sure I understand the difference between the points made in slides, I believe they were 9 and 11.
That's fine. Yeah. I think it's okay if you do it.
Sorry, it was actually...
Yeah.
Actually, it was 7 and 9. So I'm trying to wrap my head around the difference between the funding sources. So on slide 7, we talk about $55 billion roughly being spent on medical care in 2018 for Washington residents. But then at the bottom of that slide, it talks about a Friedman estimate of an additional $28 billion being necessary.
Oh, okay. Yeah, let me talk about that. What these single-payer studies do is they try to estimate what total spending would be if single-payer would be adopted versus what it would be under the current regime, under the Affordable Care Act and the way things are run now. Friedman's study in particular estimated that there'd be substantial savings from single payer. Roughly, he estimated that spending would decrease by 10%. Okay? So if you take that 10% savings and then but you take away all the employer-sponsored care and have to replace it with taxes, you would need an additional $28 billion in revenues to pay for that system, even taking into account the taxes. Yes, yeah. So
is that essentially a one-for-one conversion of ESI premiums and other cost sharing into additional tax revenue? So we're swapping $128 billion for another $28 billion.
Yeah. It's more complicated than that. There's a lot of things going on. One is you have employer premiums being replaced, employee premiums being replaced, all the cost sharing throughout the whole system that we now have being replaced, the uninsured being covered, and then less the savings the potential cost savings that occur within the system. And then when you take that all into account, you need an additional $28 billion in taxes to fund the system, even if we had the monies going to Medicare and Medicaid in it.
So we go from 55 billion roughly in 2018 to effectively 83 billion in costs?
No. This is tax revenues that would be needed to fund. Right now, the system, about half of it is funded publicly.
Right.
Through taxes, basically.
Okay, so I think I'm understanding where Patrick's question is coming from. You're asking, is that 55 billion taxpayer dollars now, or is that?
Oh, the 55 billion is total spending from all sources.
So it includes a lot of sources, okay.
So the 28 billion replaces whose share? And is it replacement of, so dollars in lieu? So $28 billion comes magically from somewhere. Is that $28 billion replacing the employer response to the other premiums,
yes,
converted taxes? And then we assume also that the remaining 28 billion that we're getting from federal and state sources would continue.
That's right.
In the same amount.
Yes. Yeah. Basically, that's it. Yeah.
Is everyone tracking that?
Okay, so I appreciate this, and I know the job you were asked to do is difficult, and so this is going to come off a little bit critical and recognizing the challenge. So on the one hand, I think I appreciate the comparisons that you're making in these slides, but I think they're incomplete, and I would just like this group to recognize that it's a place to start. So just as an example, in the pros and cons slide, I can't remember, on page 8, you note that a disadvantage of a single payer is disruption of employment, but you don't include, you don't note that the current system creates job lock, which is an employment-related negative effect. So just to say that there's a lot you probably couldn't include in these slides that we need to be cognizant of. I wouldn't.
That's fair.
I wouldn't. So that's one thing. But the larger issue is that I think you miss in the description of single payer the two most important forces that would likely reduce overall spending. One is that single payer systems, or actually the multiple payer systems that you are going to be talking about, all have a mechanism for controlling the amount of money going into the system. And that is a spigot.
And we're going to talk about that.
Okay. So to me, that's perhaps the single most important vehicle for controlling costs. And the second that's sort of related is that we have a very fragmented system. And the result of our fragmented system is that there's a stronger incentive to shift problems and costs to somebody else than there is to actually control or manage costs. So the fragmentation of our system is, to me, at the base of the inefficiencies. And you don't really mention that here as a key aspect, let's say, of single payer or multi-payer systems. So just to point out that to me, those are the critical things, and why I made that comment at the beginning about, while all 5 bullets in our charge are important, if you don't solve the big financing problem, the rest of the stuff isn't going to happen. The innovation isn't going to happen. The transparency is not going to happen, because we just are left with a fragmented system.
So I heard 3 big things that came out. I just want to summarize for everyone for the benefit of our notes. The first is that we have to caveat that. I'm sorry. Thank you. We have to caveat that in this slide deck that it's pretty high level, and so we're missing some nuance there, and it's a big nuance that is something that we should all be aware of. And then that there are 2 major problems with our system now that we're not addressing, that single payer might address, one being the spigot. There's a finite amount of money that would go into the system. And then the second being that when you have a fragmented system, the incentive is not to keep costs down, but rather to just get someone else to pay for it. Okay, did I see any more? Oh, yeah. Okay, you answered your own question. Excellent. All right, any others? Okay, let's keep going then.
Okay, and I think in the report there's more there certainly, but also I think in the next half hour we'll come back to some of these again, not all of them. Now then, let's shift gears and look at the comparison with other countries. This is the slide, health care systems in comparison countries. Other high-income countries that we looked at, those 10 countries, they've all achieved universal coverage, and they've all achieved substantially lower healthcare spending than in the U.S. Some have done so with single-payer systems, and others with multi-payer insurance-based systems. And so we really looked at examples of both in the report. Within the single-payer country, among the single-payer countries, there's two sort of flavors of single-payer. Some of the countries have national health services, where many of the hospitals and clinics are government-owned, and many physicians are government employees. The UK and Scandinavian countries fall into that group. Others have national health insurance systems where providers are typically private, but they're reimbursed through through a single tax-financed government plan. And Canada is the example that we hear most about there. And in the report, the Canada system's profiled in more detail. Among the multi-payer countries, they all have mandatory health insurance systems. Everyone has to be covered. Germany, the Netherlands, and Switzerland are profiled in the report. Coverage in these multi-payer countries is administered through multiple, mostly nonprofit insurers. People are free to choose insurers, and they can change plans at least every year. But again, they're required to have coverage. Insurers are required to accept all applicants. And the financing varies across countries, but it's usually a blend of taxes, premiums, and out-of-pocket spending. Okay, the next slide, government roles. The roles of government, insurers, and providers in administering these systems varies across the countries. In general, these governments intervene more than we do in the U.S. They play a greater role in the healthcare market. Among the countries we profile, the Swiss and the Dutch systems are more market-oriented than some of the others. If you look at what these governments do, first of all, they heavily regulate insurers. They control margins, markup among insurers. They subsidize coverage for residents with low incomes in a more complete way. They determine standardized health benefit packages. Everyone gets the same benefits. You know, if you go and get individual coverage in the U.S., you might be getting you'll be getting different benefits in some employer-sponsored plans. That doesn't happen there. Everyone gets the same uniform package. And this last point, they control the prices of medical services and pharmaceuticals, and they do this in different ways, and we'll talk more about this in a minute. The first thing that I wanted to do in this comparison, though, because it's so important, is to talk about healthcare costs, and that's the healthcare cost comparison slide. The U.S. spends about 18% of our gross domestic product on healthcare. These other countries spend about 11%. We spend about $9,400 per person in the U.S. They spend on average $5,000. Spending per capita in these countries does vary, and that's what you see in the graph on that page. What we have there on the vertical axis is healthcare spending per capita in the country, and on the horizontal axis is the GDP per capita, or the income level roughly of that country. And what you can see is spending increases with income, is what you'd expect. But all those other countries are in a tight relationship. They're all on that line. As income goes up, they spend slightly more. The U.S., though, is an outlier. For the U.S. dot on that chart to come down to these other countries, our spending would have to decrease by 30%. Okay. Well, why is this a concern? Well, a lot of the other problems we talk about are really driven by cost. A lot of the access issues, especially financial access, it's driven by cost. Unfortunately, a lot of that spending's wasteful in the sense that it doesn't produce better health, is what some studies show. A lot of the increase in cost is just because we're paying more for things than in other countries. So And we're concerned about that because households and governments could use that money in other ways. That, you know, we could spend more on other important things. So that's why we're interested in cost. In the next slide, we start talking about what's driving those differences. Why are we 30% higher? And the literature identifies 4 things that are important. First of all, there's higher prices for medical services and goods, and we'll talk about that. We spend more for these things in the U.S. Of those prices, the most important we'll see is pharmaceuticals. That's a really big one. Secondly, there are certain procedures and advanced imaging that we do more often than in other countries. We'll talk about that. That's a big contributor. Thirdly, there are administrative costs. And we'll look at insurer administrative costs, and we'll also look at provider administrative costs as generating a lot of that higher costs. And in the long term, it's how we deal with new technologies in the U.S. that are driving higher costs in the future. And that's the profile that I want to talk about in the next 4 slides. Let's start with pharmaceuticals. We spend about $1,400 per person on pharmaceuticals. Other countries spend about $670 on average. In the report, we talk about some of the things these other countries do. The primary thing is they have centralized price negotiations with pharmaceutical companies. Governments negotiate with pharmaceutical companies on the prices. That difference in per capita pharmaceutical spending would explain about 21% of the differential in costs that we're observing between the U.S. and other countries. Other fees, other prices, provider fees and budgets. How fees and provider fees are set vary from country to country. In the single-payer countries, governments largely determine reimbursement rates for hospitals and physicians. This would be similar to what's done with Medicare in the U.S., but for all care, it's set. And that way, those issues of cost shifting don't arise because the system's not fragmented. The method of payment is also important. Fee-for-service is still used widely in these other countries, paying a physician for each service they provide. Capitations use some amount, giving clinics and doctors a fixed amount per each patient. One thing that has been used, especially for hospitals in these other countries, are what's called global budgets. They'll budget and give a hospital an annual amount to do all the care that hospital provides. Countries that we looked at, many of them are shifting away from global budgets out of concerns for wait times. They moved to case-based payments in order to make sure there was enough supply in the system. In multi-payer countries, again, the rates, how rates are determined varies. In some, the government also sets reimbursement rates for some subset of all care. They may set the rates for doctors, for example. In some countries, fees are determined by negotiations between provider associations and insurer associations. The difference, though, is that it's not so much a single insurer negotiating with a single provider, but they do it collectively at the provincial or the national level as associations. They do it all in one room together. And if they can't agree, the government might step in to help set the rates. High margin procedures, what do we mean by that? Well, these are things like knee replacements, hysterectomies, cataract surgery, coronary artery bypass, angioplasty, and imaging, MRIs and CTs. We have higher utilization of those than many other countries. In other words, per person we use more than many other countries. We also spend more per unit of those things. For example, A coronary artery bypass in the U.S., this is old data, but it was about $75,000 on average. In the Netherlands, it's about $16,000. In Switzerland, about $36,000. So for each service, they're paying about half. CT scan in the U.S., an average around $900 versus, say, $400 in Switzerland. And the paper has more examples of those price differences. There was a recent study that roughly estimated that just 25 of those high-margin procedures could explain about 20% of the difference in costs between the U.S. and these other countries. Advanced imaging alone, 7% of the difference. Administrative costs. Let's talk about that now. Insurance administrative costs are higher in the U.S. because we have a fragmented multi-payer system. Insurance administration costs are what proportion of total premiums that we pay insurers go to administrative versus care, administrative issues instead of care. In single-payer countries, that's typically about 2 to 3%. In these multi-payer countries in Europe, it's 4 to 5%. In the U.S., on average, 8%. So those differences in administrative costs of the system would explain at least 15% of the total difference in cost between us and other countries. Above and beyond that, there are administrative costs borne by providers. Hospitals have to have big billing departments to deal with multiple payers. Clinics have the same issue. There have been studies, mostly comparing Canada and the U.S., that provide substantial costs associated, borne by the system through providers. The next slide illustrates differences across countries in administrative burden on providers. It's the administrative costs.
Yeah. I want to make sure we get to some of the stuff that folks are interested in, technological innovation and outcomes. So if you could take us through pretty quickly the rest of the cost ones. I don't know if this one's one you could speak through a little more.
Okay, I think this is the last one on cost, except for technological. Just basically what this shows is it's a survey that's done every year of primary care physicians in different countries, and it asks them, how much time do you spend on administrative issues? Is it a burden? They look at things like insurance claims, billing disputes, and this is where governments play a role. Clinical or quality data reported to governments. In the U.S., they report high burden, but also in those multi-payer countries in Europe, like Germany, Netherlands, and Switzerland, the burden's also high. That burden is lower among the single-payer countries like the UK and Canada. Okay, let's talk about, there's a slide on physician compensation. Let me just briefly say that we do pay physicians and nurses more in the U.S. than in other countries. Despite that, though, it's not a very large driver of cost because we have fewer doctors per person in the U.S. than a lot of these other countries. We estimate that maybe that explains about 4% of the difference.
So is this a good time to pause and get questions?
Yeah, sure.
Okay. So I have Kristen Hacker up and then Devin.
I was just curious about the MRI and CAT scan slide. Are there subsidies to obtain those type of equipments usually seen in other nations, or? Through government, or?
That's a good question. I do not know. I think it probably varies if there are. I don't think they'd... For example, Switzerland. If MRIs and CTs are done within a hospital, the hospital sector in Switzerland is heavily subsidized. So that would probably occur. That might not be the case in other countries.
So I have a question about an area of cost that I haven't seen in the report. One of my understandings is that one of the leading causes of personal bankruptcy in the United States is medical debt. So inherently then, when people file for bankruptcy, that whole legal process adds to the total cost, right? Because then hospitals and providers have to eat that cost. Also, what kind of legal fees, et cetera, that are, incorporated into the total cost of operating as a provider or an insurer when people's procedures aren't covered and then they can't, pay the bill or whatever that is. So for me, looking at this, I'm wondering where are the numbers there that are also associated with the current cost of the United States total kind of spending?
So what's the impact of medical debt on
yeah.
the United States and other countries?
Legal, across the board, right? Yeah.
Yeah, that we did not see studies on that we reviewed. That they may be out there, so that's something we'd have to look at.
Dr. Kovac.
Comment and a question. I think for comparison, it might be helpful. I believe that none of these countries have anything even close to what we call a narrow network. And that's a big deal in terms of access to care. And I think that's worth making sure everyone really understands that doesn't exist in other parts of the world. And the other one was the question. I saw some eyebrows raised at the U.S. 8% administrative costs. My understanding, I would have thought it's much higher. My understanding was that was one of the things that got stripped away from the effort to enact the ACA in 2013, that the industry got rid of that kind of regulation, which was allowed up to like 250% higher than this. If I could be, maybe I'm missing something.
Well, the 8% figure is the one that's listed in the OECD estimates. And it's one that I see often cited. It probably varies from insurer to insurer and from state to state, but that's the number that's coming out of that.
It's just that the magnitude of difference between these other countries is a central argument to a Medicare for all type of approach, and the scale here just doesn't look nearly of what I thought it was, and it just would be good to useful to really fact check that and some other.
Okay. To validate that 8%,
yes.
Because it doesn't jive with your impression
yes.
of the system. Okay. I think Don.
The only thing that I have a question about is that I've had the experience of taking foreign doctors through our hospitals and having them look at what we're doing, and almost invariably they comment that we have a fetish on modernizing our equipment like CTs and MRIs and that kind of stuff unnecessarily, and they're always surprised that we're throwing away equipment that can be utilized. And have you done any studies on that?
Well, something related was a slide I forgot to talk about that maybe we could turn to, the technological innovation slide. It's not directly talking about equipment per se, but more general how we deal with technologies in the U.S. What that technological innovation slide shows is, first of all, if you look at the graph, this is over time, over like a 30-year span, what proportion of our spending, our GDP, goes to healthcare. Back in the mid-'70s, we were on par with other countries. We spent roughly about the same percent as Canada. Over the next 25 or 30 years, though, costs went up much more quickly in the U.S. than these other countries, and that's where we diverged. Do you see that technological innovation slide? Number 19. Yeah, number 19. Well, the way economists explain this is that over this period, starting in the mid-'70s, there was an explosion in innovation in medical technology. New drugs, new procedures, new devices. What they believe happened is that these other countries were better at restricting the use of technologies that had limited usefulness, limited efficacy. They did a better job of that than we do. Through regulating what procedures they pay for, limiting the supply, trying to curb the oversupply of MRIs or CTs within the system, things like that. Yeah, and we'll see what outcomes that generated.
I'm going to take us through the rest of these questions here.
I just also wanted to remark that I don't see any figures about the cost of delayed health care and the kind of savings that we would get from not having that be such a huge issue for Americans anymore.
Yeah, and again, I think that's important, but we didn't have data on that. Sorry.
Yeah, it seems pretty clear from your report that one major thing that these countries are able to use in order to achieve universal health care at an affordable price for people is they're either setting the price of drugs or setting the price of healthcare services or getting in the middle of negotiations between multiple payers and the providers and the pharmaceutical manufacturers. And I'm curious if in your full report or other research that you have, if you have a comparison about what those 10 countries are paying for services compared to what the United States, what we pay for those services in our different fragmented markets. Of course, it's a different amount that we pay in those different markets, but I think that is a really interesting thing to look at because what we pay, our premiums, our deductibles, it's all related to the cost of drugs, the cost of hospital services, and the cost of provider services.
So what's the delta between what we're experiencing in the U.S. and what we're seeing there?
Yeah, I'm just curious if we have a comparison there.
There's not a very complete picture of that, but there are more examples of price differences for selected procedures and drugs in the report, and some references that would lead you to more.
It is going to be much greater. Primary surgical specialties maybe 35, 40%, primary care 50% plus. So overhead is a significant problem for physicians. As for the barriers to single payer, I would hope that we would put the excellent RAND study from Oregon up on our website. The whole, maybe a third of the body of the report talks about the significant barriers to single payer. They still said it was better than the status quo, but there are significant barriers. And also, I would hope at some point that you would give us some information or some estimate about the one multi-payer system that is developing in this country, and that's in Maryland. They call it an all-payer system. They do yearly reports to CMS. I think that's a really good model about a direction that we could take in the state of Washington, and something we ought to be considering.
And the reference to the RAND studies in the report. Yeah.
Yeah, you mentioned, the driving force of the rise of technology and increased utilization. I think one of the big factors behind that was the rise of specialization in the U.S. And that actually occurred about 10 years prior to 1970, when medical schools began focusing on making not just orthopedic surgeons, but high-end, procedure-driven orthopedic surgeons. So when you look at neighborhoods in terms of the number of, well, I'm not going to pick on a specialty, but the number of procedural specialties in that neighborhood, that will drive the number of procedures that are done. It will drive the number of MRIs and CTs that are done, and it will really also drive the utilization by hospitals depending on all these procedures.
So that echoes, I think, what we heard from the study that we had an attraction to higher costs.
Yeah, I mean, we love technology. And I'd also point out that in other countries, one of the big reasons for having higher or better outcomes is they have a much more secure primary care base, which does not exist in the U.S.
Okay, I'm going to do another contract. It's already so it's going to be about this, but we have to get to our public comment. 20 minutes to 2 hours. So I'm going to ask everyone, you can keep your comment really because I know that it's been made. There's echoing. If you could skip it this time, so we can go to 2 slides. I know people really want to see this. So Kristen and Carrie, and then I'm going to do one.
Just wanted to go back to the administrative cost. I think it'd be important to include some kind of percentage for the provider administrative cost.
Yeah, and actually that might be some of the confusion here with that. That 8% number is Insure administrative costs on average. That doesn't include all the overhead that we're talking about from the provider. So I don't know if that's part of what.
I think that'd be, yeah.
And there is some more on that in the report, but yeah.
Especially looking at reimbursement models, possibly under universal coverage, and also is malpractice coverage addressed in here at all? Because that has been a huge part of the debate. That is very different from other parts of the world.
Yeah, it's not addressed in the report, but in the literature we're looking at tended to sort of discount the size of the impact of that, actually.
I'll be quick. I think Kelly hit on this a little bit, but in talking about trying to capture some of these other costs, I do think it's very important when we, and I know it's very difficult, and so even if we can have examples that we start to dive into as we move through this, we're looking at some big numbers here, $28 billion or whatever, but it is very difficult. I know from a chronic disease perspective, we're always trying to do this, is look at what is the cost saving and what is the cost saving of someone who has insurance and then can be diagnosed with stage 1 breast cancer instead of stage 4 breast cancer. Like, that is significant cost to the system that needs to be weighed when we're looking at making major investments, because people are going to have sticker shock from that $28 billion or whatever the cost is. But there is more, there's a lot of costs in here that we're talking about, but that is also something that is very difficult to capture. It's impossible to capture, to own that. But if we can have some examples like that, for someone with hemophilia, if we're talking about the cost of factor, which is a very expensive drug, versus the cost of hitting the emergency department with a bleed. And there's costs beyond that. It's bigger economic costs, which is definitely impossible to capture. But I do think it's important to have a conversation about those in this as we look at what it costs to invest in the system, whether it's extending another branch into a multi-system, whether it's single payer, those things are all going to cost money, but the cost savings of those things is very, very important. Yeah. Yes, thank you.
All right, let's see if we can zoom it down, not do justice to.
So 5 minutes for the rest? Okay. Well, let's jump to access to care. Just saying a few things about that. It's, again, just broad comparisons of the U.S. with other countries. Access can be limited in 2 ways. One, financial reasons, and we'll look at that in a second. But let's look at first potential care rationing, and that is like, how long do you have to wait to see a specialist, for example, or wait for an elective surgery? That's what's shown in the left-hand panel of the access to care slide. It's just saying, it's reflecting how long people in different countries have to wait for certain kinds of care. In the U.S., those waits are relatively low, and they're relatively low in other insurance-based systems in other countries, and a bit higher in the universal coverage countries, especially Canada. The other way, again, access to care can be constrained is through financial burden. So these are the results of a survey which asks, in the last year, did you not get a certain kind of care? Did you forego a prescription? Did you not visit a doctor or not get recommended treatment because of the cost of that care to you? And we can see that in the U.S. we're an outlier, and that about a third of people said yes to that one in the U.S., whereas in these other countries they did not. why is it higher in the U.S.? Well, there's two reasons. If we go to the next slide on financial barriers, one is that out-of-pocket costs are relatively high in the U.S. They're actually higher in Switzerland, but in Switzerland, everyone's covered, so they don't report as high a level of access issues that we do. By out-of-pocket costs, let's just review what we're talking about. We're talking about cost sharing, like co-pays and deductibles. We're talking about payments for services that aren't covered. It's the dental and vision that was brought up earlier. We're talking about payments for services for people who aren't insured, because everything's out of pocket for them. When you look at that, the U.S. has relatively high out-of-pocket, but some of these other countries are close, and yet they have better access, less reported financial access issues. And that is believed to be because other countries cap out-of-pocket payments better than we do, or more completely than we do. They cap out-of-pocket payments at relatively low amounts to reduce cost sharing, especially for vulnerable populations, those with low income, children, people with chronic diseases, and older adults. So through targeted capping of cost sharing, they're able to reduce those barriers. The last three slides are about health outcomes and quality of care, largely because I don't understand those issues very well because they're so hard to deal with. No, I'm just joking. We don't have a lot of time for that, but let me just say that when you compare the U.S. to other countries in terms of broad measures of health outcomes and measures of health quality of care, the evidence is really mixed. On some things we do much better, and some things we do much worse. But it's hard to understand that because health outcomes are largely driven by non-healthcare system things like behavior.